Good morning. I'm Dr. Gloria Alexander, President of the AIDS Society of India. I warmly welcome all of you to this workshop, which is a collaboration between AIDS Society of India and the Mumbai Society of Obstetricians and Gynecologists. I warmly welcome Dr. Rajendra Sankpal, who's the President of MOGS, and Dr. Kedar Ganla, who's the Secretary General of MOGS. The AIDS Society of India, as you know, is the country's largest professional non-profit membership association of doctors and researchers working in the field of HIV. We are focused mainly in three areas, that is clinical management, education, and advocacy. Last year, we celebrated 25 years of our existence. The organization was started in the year 2000. We conduct CMEs, webinars, seminars, and last year we also published a newsletter. But our flagship event actually is the AIDS conference that we conduct in different parts of the country every year. So this year we had the conference at Mumbai. Normally the conference is of 3 days duration, but this year when the office bearers had a discussion, we decided we'd keep it only for 2 days and that we would extend the timing so we could give the same amount of information, and but keep it on only for 2 days. So we decided that it would be on the 6th and 7th of March, which was a Friday and a Saturday. And then suddenly we realized that Sunday is the 8th of March and it is International Women's Day. So it was a day that we could not ignore. So we thought we should do something, and that since we work in the field of HIV, why not focus on the woman living with HIV? And we wanted to collaborate with women. So of course, Trupti suggested the Mumbai Society of Obstetricians and Gynecologists. She contacted them and it all worked out. And here we are today conducting this workshop on integrating HIV care and STI care in women's health. You know that women living with HIV have borne the brunt of the pandemic, of the HIV pandemic, and I hope that we will leave this workshop learning from each other, gaining a lot of information, and understanding that the epidemic is not just about the virus, it's also about the people who are living with HIV, especially the women. So thank you all for being here, and we'll go ahead and start. I'd like Dr. Rajendra Sankpal to say a few words.
Good morning. Thank you. At the outset, I must thank with our participation, collaboration with the AIDS Society of India. So if you know, when every woman in every part of the world, when the woman walks into a clinic, not knowing that a silent infection which she has acquired might change her life, change her dignity, change her reproductive outcome, change her the fertility aspects. And as Madam said, it is so prevalent now that we have to take care, as an obstetrician and gynecologist, we have got opportunity to take care of women in every aspect of their life. Today on the International Women's Day, we gathered not just to discuss HIV and sexually transmitted infections, but we would like to reaffirm our responsibility to take care of women who trust us with their health. Respected Dr. Glory Alexander, President of AIDS Society, Dr. Trupti Gilada, and my mentor and Dr. Gilada. I was associated with him almost 40 years back at Grand Medical College and JJ Hospital. Good morning, and it gives me immense pleasure to welcome you all for this unique collaboration of the Mumbai Obstetrics and Gynaecological Society and AIDS Society of India. Mumbai Obstetrics and Gynaecological Society is 91 years old, and it has got academic legacy of more than 9 decades. As the president of 72nd president of Mumbai Obstetrics and Gynecology, we are always in the forefront of sharing knowledge, improving clinical practice, and taking care of women's health. And today's collaboration is aligning with that mission of our spreading knowledge. Collaboration between two of us, giant bodies, Mumbai Obstetrics and Gynecological Society and AIDS Society of India. In this my presidential year, our theme was precision, protection and progress. This is our presidential theme for 2025-26, precision, and this exactly gets aligned with today's seminar and a workshop, precision in diagnosis of HIV and sexually transmitted infections, protecting women, and progress is embarking on prevention of loss of dignity and taking care of the dignity of women associated with HIV and sexually transmitted infections, and collaborating with the other bodies such as AIDS Society of India and other bodies. During this last 1 year, we had good collaboration and unique collaborations. We had international conference on endometriosis with the European Society of Gynaecological Endoscopy. That was held in June. We had collaboration with the Indian Society of Menopause. We had also collaboration with Endocrinological Society, Trust of Society of Endocrinology and Diabetology. And today we are here, we are collaborating another milestone in our career of MOGS, that is collaboration with the AIDS Society of India. I think the next generation medicine is always collaboration of the different specialities and different organizations. I would like to share a powerful thought that the measure of a society is how it treats its women. I would like to congratulate the organizing team of this particular workshop for having, and my colleagues and the mentors here for collaborating for this noble cause and spreading the knowledge. As a gynecologist, we have privilege to protect women at every stage of life. Let us remember that HIV is a virus, but stigma is a disease. Science can take care of the virus, but compassionate care will take care of the disease, and that's the stigma. As a gynecologist, we are privileged to take care of women at every stage of life. So let us move forward with precision, protection, and progress for humanity. Because when we protect a woman, we protect the future of the world. Thank you so much. Dr. Kedar Ganla is our dynamic secretary of MOGS, taking care of every possible office work at every stage.
I remember in 1994 when I was with Dr. Kaizad Damania, I had a doctor coming from all the way from interiors of Maharashtra with a positive report. And she was a general practitioner, and the way Dr. Kaizad Damania handled the case with the help of the consultants, today she has 2 children and she's still having a good practice and a good health for herself. So I think we are making progress. We have achieved a lot, because I did not believe that she would survive for so long, because I thought so. So maybe today I learned something more. Thank you very much for your contribution for this deadly disease. Thank you.
Thank you so much, Dr. Sankpal and Dr. Ganla, for joining us and all the members of MOGS as well. We'll move on to our first session. For that, I would like to invite Dr. Kedar Ganla and Dr. Ritu Hinduja. In this conference, we tried something new. I think you have fun with it as well. We have some introductory videos made by AI by our very creative Mr. Varun from Mysore. And the prompt that he's given is to make you look younger but still recognizable. So let's see what AI has come up with.
Clinician from Mumbai, she plays a pivotal role in advancing sexual and reproductive health care for people living with HIV, with a strong focus on contraception counseling, fertility planning, and patient-centered care. Today, she speaks on contraception, fertility, or surgeries.
Hello everyone, good morning. I'm Dr. Lakshmi Godbole. I'm going to be speaking today on contraception, fertility and operating on patients who are HIV positive. So I'm just going to be touching a little bit on the important points. So let's first go to contraception. I think when a patient who is HIV positive and is on antiretroviral therapy comes to us in the clinic and wants to know what her options are for contraception, then this would be quite useful for us to know. I think most of us are not quite sure, can I give combined oral contraceptive pills with all the medications that she's taking? Can I put a copper T in this woman? So the recommended method of contraception would be intrauterine devices, both hormonal, that is Mirena as we know, or copper T, as well as DMPA injections, because they are not affected by any drug-drug interactions with antiretroviral therapy. I think that also the important point we need to make to the patients is that irrespective of what they are using, they also would need to use condoms, because though the IUD and DMPA would prevent unwanted pregnancy, they wouldn't prevent her from getting any sexually transmitted infections. So condoms should be advised for this reason. If we deem it necessary, or if the patient is very keen to take birth control pills, then we need to ensure that whatever medications she's taking, they do not interfere with the absorption of these pills and the effect of these pills. So both the combined oral contraceptive pills, which contain estrogen and progesterone, as well as the progesterone-only pills, they may be affected by the drug-drug interaction. But as I understand, nowadays we give TLD, which is the, I think, ART of choice, and they do not have any interaction with these medications. So if the patient is on TLD, then we could give these medicines as well safely for contraception if that's the patient's choice. There are other barrier methods that patients might want to use, though not very commonly here, like the diaphragm or the cervical cap, which are women used barrier methods. They are not recommended in this group because they do not prevent transmission of HIV, unlike the male condom, and they also have a higher failure rate. If a patient comes to us and she hasn't used contraception and she wants emergency contraception, within the first 5 days, copper T would be the method of choice. So if she's not on the typical TLD medication and she's taking something else, then what we need to know is that our hormonal contraceptive drugs might have an interaction with the ART that she's taking, especially with drugs which induce hepatic cytochrome P450 enzymes. The ARTs associated with these are NNRTIs like efavirenz, which I don't think we use anymore, and ritonavir boosted PIs. There might be some outpatient who might be taking this, and if that is the case and you're not quite sure, it might be a good idea to involve the ID specialist or her HIV physician, so that we are clear that what we are giving is not going to have an interaction. Moving on to fertility. If we have couples, either both are HIV positive, which is seroconcordant couples, or we have one partner positive and the other negative, which is a serodiscordant couple, and they wish to have their own baby, what do we do? How do we counsel them? Right? So in this day and age, when there is much reduced vertical transmission, when there is increased life expectancy because of very effective medications, many patients wish to have their own biological children. So the first thing we need to talk to them about is whether they are taking their medications and whether they have a detectable viral load. And if the patient is not on antiretroviral therapy, say if she's recently diagnosed, or they have a very high unsuppressed viral load, the first thing we need to do is ensure that they do take medications, consult with a HIV physician, and then delay pregnancy until their HIV levels are suppressed, or until at least 6 months after starting the antiretroviral therapy, so that their vertical transmission risk is also reduced, and if one partner is negative and the other is positive, the risk of transmission to the other partner is also reduced. We also need to be aware that if a patient is on ART and has an undetectable viral load, then the importance of U is equal to U needs to be discussed. So, which is undetectable viral load means untransmittable virus, so then they could possibly have sex safely. Pre-conception, we need to encourage patients to share their HIV status with the partners if not already done. And we need to start folic acid as we would do with any other woman. Now, if the patient is not on medications, or not willing to take medications, or despite medications has still high unsuppressed viral load, then there are certain techniques that we could advise, which I will talk about in some time, which is timed condomless sexual intercourse, or sperm washing to reduce the risk of transmitting HIV to the other partner, or use of pre or post-exposure prophylaxis. How does the virus itself affect fertility? Right? It could affect it directly or indirectly. Having HIV and AIDS, which is severe immunosuppression, can impact ovulation and ovarian reserve adversely. Also, this might be a cohort of patients who are at increased risk of sexually transmitted infections. So that factor could affect the tubal fertility. If a man is infected, the virus itself and possibly the treatment can be associated with low sperm counts and motility, which has been shown in several studies. And certain ART medications like zidovudine can cause mitochondrial toxicity, which can affect oogenesis and spermatogenesis. So a patient living with HIV might have issues getting pregnant because of all these reasons. So if they want to know, how do I get pregnant? How do I have my own biological children? So if you have a serodiscordant couple in which the male partner is HIV positive, but the female partner is uninfected, then obviously treatment of the male partner with antiretroviral therapy would be the first thing that we would do. And in case they want to plan a pregnancy, despite our advice to wait for 6 months or to wait till the viral load is fully suppressed, then what we could advise is maybe just have timed unprotected intercourse only at the time of ovulation, so that we reduce the risk of the female partner getting HIV, and administering pre-exposure prophylaxis to the female partner. The pre-exposure prophylaxis is usually medications that would be given to the female partner on a daily basis usually, and then she would have retesting of HIV every 3 months to make sure that she is not positive. Now, if they wish to use artificial reproductive technologies, then sperm washing for IUI or IVF like ICSI would reduce the risk of transmitting the virus to the female partner and the offspring. So this is based on the observation that HIV is mainly present in the seminal fluid and not attached to or infecting the sperm. If you have a different scenario where the woman is HIV positive, but her male partner is uninfected, and again, if her viral load is not suppressed or she is not taking ART properly, and they still want to have a baby despite our advice, then this is something that has been, said that it can reduce the transmission to the male partner, which is homologous insemination, where she collects the semen of the partner in a condom, uses a syringe without a needle to take it and inject it high in her own vagina. I don't know how practically this is possible, but it's something that can be discussed with the patient, and she could be offered IUI or ICSI when appropriate. There are alternatives like sperm donation, and in real case scenarios where you think it's not possible for them to have their own children for whatever reason, then adoption can also be discussed. If you have a heterosexual couple where the partner or both partners have suppressed and low undetectable viral load, in these patients, in my practice, I usually see these patients who are already on ART who do not have a viral load detectable, then we can advise them to have condomless sex so that they can conceive naturally just like any other patient. But if we need to refer them for any further treatment because of, say, tubal fertility, then personally also we have faced that there are multiple barriers for them to access reproductive care, because irrespective of universal precautions, for an IVF or an IUI facility to outfit embryology and andrology labs with separate systems for virally infected patients, the costs might be prohibitive, and so they may not be able to access it as easily as someone else. Moving on to surgeries in HIV positive patient, I think the first thing we need to know is HIV is not a contraindication for someone to undergo a surgery, and most of them can undergo surgeries safely under appropriate conditions, and it's always a good idea to involve your HIV physician or ID specialist pre-op and post-op. If the patient needs an emergency surgery, then the main thing to keep in mind is that we shouldn't delay waiting for a viral load or for a CD4 count if we think that it is life-threatening and we need to operate. If the patient has had a recent 6-month or 12-month viral load or CD4 count, that would be good enough for us to go ahead and operate the patient. The risk of transmission from patients to doctors, I think most of us are worried that, if we get a needle prick, what am I going to get this virus? During surgical procedures, the risk from patients to doctors, it's a very low risk, 0.09 to 0.3%. After a single exposure to blood or bodily fluid. For elective surgeries, what are the investigations that we would want to do before we take the patient up for surgery? Obviously, a viral load and CD4 count. As I said, if there is a recent 6-month or a 12-month viral load and CD4 count, there is no need to check again. We would want to screen for opportunistic infections, so tuberculosis, hepatitis C, hepatitis B, pneumocystis carinii pneumonia. We would also want to test for comorbidities, because some patients would tend to have more comorbidities like cardiovascular or thromboembolic complications. If the patient is on ART and the viral load is less than 200 and the CD4 is more than 200, then we would plan surgery like that for a patient who doesn't have HIV. But if the patient is not on ART or has unsuppressed viral load or a very low CD4 count, then to reduce the risk of surgical complications, I think we would need to confer with our HIV specialist or ID doctor for optimization. Several studies have shown that a diagnosis of AIDS, which is low CD4 count, is associated with increased post-operative mortality. So unless it's an emergency, it might be a good idea to take an opinion from the HIV physician before we go ahead. Intraoperatively, what are the considerations? I think laparoscopy is a game changer. Minimally invasive techniques are important aspect of surgical practice for our HIV positive patients. Why? Because the incision sizes are small, the recovery is faster, post-operative pain is reduced, the risk of surgical site infections is reduced, there is less surgical trauma or stress, there's reduced hospital stay. So it would be the standard choice. And while operating, just like for any other patient, we would need to use standard universal surgical precautions to prevent exposure to blood or bodily fluids. If exposure does happen and the patient is HIV positive, then we would need to go in for post-exposure prophylaxis. Anesthetists and surgeons would also need to evaluate the potential for drug-drug interactions between common perioperative medications and the medications that the patient is on, right? And if the patient is on treatment for opportunistic infections or she's on an ART, then it is very important to stress that this needs to be continued post-operatively as well. Many times we keep the patient nil by mouth post-operatively for a few hours or a day or two, depending on what surgery she's had. And so clear instructions need to be given on when to resume the medications. If the patient is unable to swallow or unable to take oral medications, maybe we could talk to our physician and consider giving equivalent doses by NG tube or by liquid formulations. But let's just not stop the medications just because she's not eating. And we need to consider that post-operatively, these patients might be at increased risk of deep vein thrombosis, so we need to consider early mobilization and if necessary, VTE prophylaxis. They are at risk of infections, and if there is any fever post-operatively, then I think it's a good idea to involve our ID specialist early and give antibiotics as appropriate and investigations as appropriate in association with them. So that would cover the pre-operative, intraoperative and the post-operative considerations for our women living with HIV. Thank you. So I think I just tried to touch upon the important aspects of these topics.
As a surgeon, how do you prevent needle prick injuries? Two gloves are fine, but do you have any solution which we can put on our hand or?
No, I don't know about any solution, but what I learned.
Antiseptic solution which prevent.
No, so Dr. Ganla, what I learned when I was in the NHS was to guard the needle. I think that's what I do most importantly. So we take a suture, and then rather than leaving the needle lying around or giving the needle on the needle holder to the nurse or to your assistant, I was taught to always guard the needle by turning it around, and I think I practice this now all the time, even when a patient is negative, because then that's a habit that we learn and we prevent pricking ourselves or our assistants or the nurses. But I'm not aware of any solution that we can use on the gloves or anything like that. I think just practicing safety with sharp instruments, making sure we don't handle the blades, scalpels and needles by just passing it to each other. That might actually be helpful. And being more mindful while suturing so that we don't prick our partners. Also, I think when we assist, we are always taught that we should be using retractors and not our own hands. In my experience, I've had some colleagues who've assisted me and they still put their hands or fingers, maybe inadvertently. So maybe it's a good idea to make sure we're always using instruments. Just good surgical practice basically to prevent pricking ourselves, even if the patient is negative.
I think the person should be a bad assistant in order to prevent.
Can I just come in on that question?
Yeah.
So, besides the surgical precautions that we can take of the needle, it's extremely important to now understand that U is equal to U, which is undetectable, is equal to untransmittable, is very, very valid. Anyway, the risk through a needle prick injury is very low. Once the patient is suppressed, some of the guidelines say PEP is not even required. So oftentimes in these scenarios when we are giving PEP is just for that little bit of doubt that we might have. It's more like, honestly, works like a placebo than anything else. So a lot of this thought about someone being positive and the surgical protection is more mental than really real fear or real risk. So I think that's one thing that as a community, not just OBGY, but even other surgical branches, that we really want to get across is that now with newer ART and with most of our patients being undetectable, there isn't any risk left to the operating surgeon.
I think, though, Trupti, it's always a good idea, whether the patient is negative or positive, that we don't try to prick ourselves or put our hands in their fluids.
That's fine.
So
But
I understand U is equal to U,
yeah.
but just generals, when we are taught surgery, we are taught not to get all these things. So I think practicing safe surgery is the first step.
Just a very basic question. What does ASRM stand for?
Oh, American Society of Reproductive Medicine.
Okay. Thank you.
Thank you. It was really a good lecture. I would
One
like
more.
to.
One more question.
Kedar.
The HIV tests have been done. There are some tests are done by the kit basis, some tests are done by three methods. And the cost difference is too much. Now, when I tell a patient to do HIV, I do not know whether they've done by kit or this. Is there a difference between the two?
I think Trupti would be able to answer this better.
The actual.
So all the
Who am I
screening,
dealing
all
with?
the screening tests now are 99.99 sensitivity.
Even the kit test.
Yeah, they're all perform the same for a screening. The reason we do 3 is if the first one is positive, then we confirm it by 2 other assays. So it's a very sensitive test.
Window period can be one issue. If the
So
person is
window period can be one issue, but one is history. The other thing is a lot of hospitals have already moved to NAT-based testing. So if they've moved to NAT-based testing, it even takes care of that window
window
period.
period.
Yeah.
That is fourth generation
Assays, yeah.
Tripti, what is NAT
NAT is
HIV
a PCR
antibody
based
analysis.
test.
All the
So a
laboratories
lot of
are not
hospitals do
doing it.
NAT based.
The cheaper ones, when we send it, the patient will
It's not
select the
required.
cheaper one. And when we tell them to go to the specific lab, they think that we have a special interest in that.
So that's why we do 3 tests using 3 different antigens or 3 different assays. And if all 3 are positive, you can be 100% sure that this patient is living with HIV. So 4th generation just helps us to reduce the window period to around 30 days.
Madam?
Actually, I wanted the question to be asked to our chairpersons. What precautions do you all take when you're handling IUIs in such couples? As a general clinician, I'd like to know.
You would like to answer?
So generally, if an IUI is done, it's mostly done either for. So why would you do an IUI for? Basically, first and foremost, if you're taking an HIV positive male semen sample into your laboratory, it needs to be well equipped. You need to have a special andrology lab where you are taking or accepting only seropositive cases. You cannot have a common lab where you're accepting seropositive known cases as well as also processing negative cases. So unless your lab is equipped with that, please do not accept these cases. Only accept cases once you are very well equipped with a laboratory that can handle seropositive cases. 1. Second, if you are well equipped, then you handle all precautions that would be required for a seropositive operative case as well, where you will use double gloves, you will wipe the table after the patient has been there, you will use probably protective equipment. But before that, of course, you need a fitness from an infectious disease specialist that she doesn't have, U is equal to U. If that is the case, she's been counseled for maternal fetal vertical transmission. All of that needs to be recorded on paper before you go ahead and perform this procedure. Also, if you're taking a donor semen sample because the husband is positive and they don't want to take a chance, then again, vertical transmission is something that you need to document on paper before you go ahead and do this IUI. So you have to bring in a multidisciplinary approach kind of a thing where they go to an infectious disease specialist, they get it down on paper, they are counseled about it, and only then you go ahead and do this. Of course, having both these, the seronegative woman documented, whatever it is, documentation is more important, and then of course we handle it like any other seropositive case.
The newer method of sperm sorters which have come, which will completely eliminate the process of sperm separation. So that becomes very easy. So we have now Zymot, where you just put 1 drop of sample here, and the other end you will get the sperms without the seminal plasma. Okay? So it's very simple, no centrifugation, no handling, nothing. Second thing is, if you don't want Zymot. Yeah, automated device. But it has to be used in level 1 only, sir, now. It's available. Secondly, if you don't want the seminal plasma to mix with the sperm, you should give medium while collecting, so that, and as soon as it is collected, you immediately process it. Don't wait for too long, because you're allowing the seminal plasma to act, the virus to act on the HIV. So that is second. Third is, when you finish the procedure, how do you discard the sample? It should be the same precautions you have to take as you take while discarding the all HIV positive samples, and post-operative, post this thing. Otherwise, procedure and everything is same, madam. You have to use those sterile gloves and all the precautions you have to carry out the same way.
Thank you, Kedar. I would like to ask one question that how long should we give post-exposure prophylaxis?
28 days.
28 days.
Anybody will take the 28 days rather than
20.
sitting on it, no?
Yeah, absolutely.
Can I speak here?
I just want to add a comment here. We have been working with HIV programs in public department, and what we have seen is being positive with HIV carries a stigma.
Yes.
And when we are looking at their reproductive rights to have conception, to healthy conception, and when it is not possible, and when we need to go for IUI or for infertility assisted reproduction technologies, if we add on to all these technical aspects, it would further put in a lot of barriers, and it would almost be like denying their rights to have a normal pregnancy. So if we have, as sir mentioned, some automated methods which can look into processing of seropositive semen samples, and if we can reduce, we cannot accept, or the lab needs to be only processing seropositive, we cannot have two different types of, what you mentioned, madam, it will put in lot of hurdles. It will be almost like denying them any possibility of having pregnancies.
To be very honest, we cannot deny. The first thing is you cannot deny. You will have to take it. Okay, now how do you deny? That is a different story. Okay. How do you deny? There is a different story for that. But we cannot deny. That is the first thing. You will have to take it.
No, but the question is, what's the intention? Is the intention to eventually deny by another way?
No, the thing is,
Or is the intention is to actually assist in getting that?
no, you will try to give them the pregnancy, but with the help of the HIV personnel to help us to identify which is safe and which is not safe. If they give us the green signal, then we should go ahead. The only thing is, cryopreserving their embryos has to be in a different container. So all those little things has to be done separately. That's all. The case has to be done, the last case in the OT, so that you can fumigate the OT. You will have to discard all the instruments, because anyway all are disposable, but these has to be discarded separately as compared to the other ones. So this is what only precautions we needed to be taken. It's not that we can deny anything. Only thing is, there can be little increase in the cost of the therapy because of the precautions we take. Yes, madam?
Why the discarding is also separately to be done?
Because it's an infective virus, no?
So the universal precaution every
Yeah, but separately, yeah.
My basic request to you is that we have been saying this, like Dr. Srikala said, in the year 2000, when 20 years back I was with Nair Hospital, and this was exactly what we were trying to tell our surgeons and gynecologists in all operations, that please do not rely on an HIV negative test. You have to treat each patient as maximal infectious. Do you know the infectiousness of hepatitis B virus? Is 30 times more than the infectiousness of the HIV virus. If today we are still talking about depending on an HIV report to take our precautionary measures, then I think we are lagging behind the global scenario, because the standard work precautions are meant to be used for each and every patient. You have to assume infectiousness of each and every sample when you are a surgeon or a gynecologist.
That will be taken
care of. But for disposing a particular sample has to be done in a particular way. You
Sir,
can't-
all biomedical-
You can't mix all samples together, that's what I feel. You
Sir,
cannot infect the same needle. You'll have to discard the needle separately.
Sir, there is no question of separation. Each biomedical fluid has to be assumed to be maximally infectious. HIV is just one report you're asking for. You're not even asking for hepatitis B or C or all other infections which are maybe not diagnosed.
No, madam, we are.
Okay, fine.
Everything. DDRL including.
Sir, I agree. I
Everything
agree.
is been asked.
My only thing is, when you look at a negative report, don't feel that we do not have to take maximal. That is my humble submission.
Universal precautions are anyway taken, madam.
I think, this is the idea of the whole collaboration, is to debate earlier beliefs and take them forward on the new scientific data.
So, madam,
So-
2024, 26 is we are completely changed.
So you will get convinced, hopefully by the end of this, that what is actually being practiced is not 24-26. It's actually still in the 90s. And we will, I think over the next few hours, come to that about how sperm samples or semen samples don't need to be actually tackled, because if you're talking about U is equal to U, and someone who's positive is actually able to have unprotected intercourse with the wife without transmitting the virus to the wife, how is that sample ever going to transmit the infection to the person handling it? So it actually doesn't need any additional precaution if the couple is.
So I think. So I'll tell you what is happening
To
here.
add one thing as a clinical microbiologist, let me please add that an HIV test is a false sense of security. Okay? Please, all surgeons, gynecologists have to understand it's a false sense of security. It is only trying to tell you whatever you want to know. Okay? It's not telling you the status of the patient. An HIV negative individual who's in the window period, see, if you see the graph, when the viral load is at its peak, okay, that is the time the patient is in the window period. The antibodies have not developed. The P24 antigen is positive. The viral load for the first 16 to 20 days is at its peak. So your HIV test is negative.
Surgeon is very happy. You know the HIV test is negative. But the fact of the matter is you are most exposed at that time. So it's high time all operating surgeons, please understand, don't rely on antibody reports.
Ma'am, can I add to this?
Yes.
So when I worked in the NHS a few years back, doing triple H for all surgical patients was not a thing. Because there's a lot of consent that you need to take before you actually test somebody for HIV or Hep B or Hep C. So we used to have elective surgeries. Only pregnant women were offered the testing compulsorily, mainly because of the risk of vertical transmission. But otherwise, elective surgeries, we used to not have this done compulsorily. And it was just understood that we have to follow universal safety precaution for everyone. And if we get a needle prick, then we would send a sample of the patient's blood and our blood as well and make sure that they are not and all that. But since I've come to India, it's compulsory to do a triple H.
I just want to add, please don't do it, because HCV, there was a recent case of a DNB fellow who, it was a rude shock to him that he was HCV positive. How he got HCV, he doesn't know. Maybe he had operated on a patient who was incubating. So don't go by the antibody results.
Can we get some more cordless mics? Or we have
I
only two?
understand. Does the microbiology report states that HIV antigen is absent, does not mean that you are not HIV carrier? Antibody. It doesn't mean that is not been written on the report. So tomorrow, if something goes wrong, then I am only at soup, no?
See, when we call clinicians to the microbiology department to understand the relevance of
No,
test,
I'm from the patient perspective.
Let me tell you,
I am asking from the patient
I have
perspective.
been in the system for 4 decades.
I am
Nobody
asking.
comes. But you will requisition, triple H. I have fought with the system that triple H is not required.
Madam, all
Can I started on this argument. Can I just ask in general? So today, if I'm sending a patient for ART, and if I know that the viral load is not detectable, this person should be managed in the regular IUI.
Madam, they are not.
They are not, but they should be, is what you all are telling me, correct? Okay, that is the lesson that I have learned. I have a question to sir. Sir, after you segregate the disposed sample, how is the negative disposed sample and positive disposed sample, how are they destroyed?
We add that bleaching
What?
powder.
Do you not add to the other one, negative one? Why not?
But that
You
is
should
not
be,
been
sir.
recommended, madam. That is not been recommended.
Sir, all samples are to be treated equally.
Madam, by saying sitting here is okay, but in municipal hospital, in a private nursing home, or in a corporate hospital, it is not followed.
It is not followed as to change.
We are. Thank you, madam. We are going in different directions. What, as a surgeon, I don't do IUIs and all, but as a surgeon, I do laparoscopic surgery. So what madam said, I correctly agreed that maybe HIV is not required, but having an HIV report, say every day and night we do surgeries, maybe 100 surgeries in a month or 200 surgeries in a month. Presence of report HIV every day, we are not that careful about each and meticulous. We are not meticulous about each and everything.
Ma'am, I'll tell you what it is.
One
It
second,
is
let
more
me
about.
finish. Let me finish.
I think she's saying we don't need only triple.
Yeah, we don't need. We don't
No,
need.
no, no. I
We don't need. We need to.
She doesn't mean that.
No, yeah. It's not required. Medically, it's not required.
Okay. No, only having a presence of report makes us little conscious that okay, this patient is probably positive. I need to take more precautions and instruct my assistant.
Take that care for
When
everybody.
your antibodies come up.
I agree with you. I am not denying with you. Madam, I agree with you. I agree with you.
It is a false sense of security. You think that every patient is HIV positive and take the necessary precautions.
We do take
I want to
every.
be loud and clear about this. Every patient consider positive and take
Yeah, that's true.
That is what we have learned through our
You
what.
may be working in a corporate hospital. Look at the public hospitals. Dr. Padmaja is here. She is representing the public hospitals.
So I understood that every patient we need to take universal precaution. That's 200% as a practical oriented presence of having an HIV report. If it is positive or negative, gives me a little more chance to be more particular about that particular
I think
patient.
we'll continue.
I understand.
I think we'll continue the debate.
Thank you.
We need some popcorn now.
You underestimated gynecologists.
No, we did not. We knew exactly this. Therefore, we called you all.
One more practical thing I will tell you on this. If I forget to do, I agree your recommendation that HIV is not required. Today I do a surgery and without doing HIV test of that particular patient, patient goes to say Himachal Pradesh and does a HIV test recommended by that doctor, and she's already positive before my surgery. And then listen to me, madam.
No, even legally it's not. That HIV
Listen
AIDS
to me, madam.
2017 says no testing.
Listen to me, at least respect what
Sorry.
president is saying. I know. These are our practical questions.
Precedents.
What? See, patient is, I have not tested the patient, followed. Now, I operated the patient. After 7-8 months, after the surgery, she goes for pregnancy and does HIV test as a routine recommendation. She comes positive. She goes to the clinician and clinician says you are HIV positive, required to go to Dr. Godbole. Okay, for special opinion, she says maybe your previous surgery you must have acquired the infection. Now who is the person? So should I do HIV test or not? That's the question. You say don't do, and I agree with that. Okay, and then the patient comes as a HIV positive, blaming me that Dr. Sankpal, you did my surgery and you transmitted the infection because of this. This is a relevant point, I'm telling you, relevant point.
No, I think
No, that is not correct, madam.
We'll address in the next talks.
Legally, you are responsible.
Yeah.
You are responsible. Because I might say, okay, she might say your instruments were not good, this, that. So many things come into picture. So that point has to taken into consideration. Though presence of having a HIV report gives a false sense of security, as madam said, and I agree with it. But this practical point, everybody should understand. I would ask our president to say a few words.
I think one medical legal case in 30 years of your practice is enough to kill you and your practice. I don't think so. I don't think so.
सुनो ना होएगा अभी नेक्स्ट टॉक में कवर होएगा आपका हम आपको प्रोटेक्ट करेंगे
नहीं मैडम आपको हाई कोर्ट में कोई नहीं आता है
Yeah, I just want to re-emphasize the importance of you is equal to you.
Correct.
You know, this is a game changer in HIV. And it's not one single study. They have done several studies, and they have done this in a total of 73,000 couples who have unprotected sexual contact with each other with a viral load that was undetectable. And when we say undetectable, we mean less than 200 copies.
Auntie, it's coming in the next talk. The whole thing is in the next thing. So
I just want to emphasize that you is equal to you is really happening. And because of that, we don't have to take so many precautions that we were taking 20 years ago. That's what we could say, you know. Since we are going to address these topics later.
और ये ऐसे बात करेंगे ना तभी हम चढ़ेंगे उनके ऊपर सब मिलके
let's Siddesh, I think let's save the questions.
One question, let me put the question to the audience and answer it later, no problem. So if you're saying that the viral load, in fact the HIV test is not required at all, if you're saying that it is something that could be in the window period, then if I am testing an antenatal patient who is turning out to be HIV negative at the moment, is it mandatory for me to prevent the mother to child transmission, that I keep testing to notice that she is positive?
That topic is next. So, I think we will begin the next topic, the HIV in pregnancy, and is to be delivered by none other than Dr. Trupti. And we would like to hear about it.
Dr. Vinita Salvi and Dr. Kaizad are
chairpersons. That's the next thing. First, I would like to invite the speaker, and we would like to invite our teachers from we learned during our residency. They are young, but still they are our teachers. Thank you, both Dr. Kaizad Damania and Dr. Vinita Salvi were professors at Wadia Hospital and KM Hospital, and also Dr. Vinita Salvi being our trustee of Mumbai Obstetrics and Gynaecological Society and past president of MOGS, and Dr. Sir is our teacher, the best brilliant teacher I have learned from him. Thank you so much, sir.
Please show the AI picture to both of them.
ASICON and MOGS welcomes Dr. Trupti Gilada, a leading clinician from Mumbai. She plays a pivotal role in advancing HIV care across diverse patient populations with a strong focus on evidence-based and patient-centered management. Today, she speaks on HIV in pregnancy practical clinical updates.
I think this is very nice, very short introduction.
Thank you so much. It's my honor to have both of you, Dr. Kaizad Damania, because I heard from Dad that you've actually led the first mother-to-child prevention program in Wadia 3 decades ago. So I think this is just perfect platform to discuss all the updates in HIV pregnancy. And thanks to all of you starting a lot of debates. Honestly, this was the idea of the whole collaborative workshop, is to start debates, exchange newer updates, and see how do we move forward. So why does this really matter? Why in HIV, in fact in all of infectious diseases, or even if we were to talk about medicine as a whole, one subject that has really gone a paradigm change is the management of HIV. In the last 3 decades, we've just seen a lot of new drugs come in and a lot of progress in the way people living right up to their expected lifespan. But even with all those things, we still have 1.3 million pregnant women living with HIV each year. And you can see that this is one field of medicine where we've really been able to bring down the risk from almost 1/3 to less than 1%. Now the target given to each of the countries across the globe is elimination of MTCT. Now, if a target is given, it means it's achievable. And we need to see how is it achievable. It's not achievable by not offering things to the people who should receive care or IUI or pregnancy or surgeries. It's achievable by doing all of that plus adding on all the updates that we have from the ARVs. So this is something that we saw in TOI a few weeks ago about what adult prevalence in India is, and we've come a long way to really coming to 0.2%. Our newer infections still remain at around 70,000 per year. But India is one of the countries which has seen the highest decline in the number of new infections, and this highest decline has been only possible because of the new ARVs that we will be talking about. This is the number of HIV women with HIV in India each year, and it's a substantial number. Many of these are women that we see as well. So just to take you through what this goal actually means. In 2015, the UNAIDS gave each of the countries a goal of what is called 90-90-90 by 2020. We've crossed 2020. The goal given to each of the countries now is 95-95-95. The first 95 means that 95% of individuals with HIV should be aware of their HIV status. The only way to do that is to be able to test. The only way to be able to test them is to remove that stigma. Because if we don't remove that stigma, people will not come forward for testing. Of course, we are talking about testing in pre-op setups and prenatal setups, but that still doesn't pick up everyone. Once you diagnose those 95% of the cases, we should be able to put 95% of them on treatment. And once we put them on treatment, we need to really follow the adherence counseling so that at least 95% of them remain virally suppressed. And why is there so much emphasis on viral suppression is why we are having this session. There has just been so much in that viral suppression that what we did 20 years back doesn't stand true today. And with all of this, the idea is zero discrimination. So I think if there's one thing that we need to go from here is go with the idea that every person living with HIV will be treated exactly in the same way as an uninfected person. So if we were to look at all of this, we will still see that it's 95% off a 95% off a 95%, right? So it doesn't add up to 95%, it still remains at 86%. So when we talk about modes of transmission, the most common methods of transmission even today remain unprotected sexual intercourse with someone who's infected and not on treatment or virally suppressed, and sharing needles in injection drug use. The almost eliminated risk factors is mother-to-child transmission and infection from blood products, because at blood banks, most blood banks have moved to NAT-based testing, where the window period is shortened and we are at least able to eliminate most of the bloodborne infections. But we are still not at zero, and therefore this discussion. Like Dr. Glory has been saying, and like this entire community, that we really want to tell you is that U is equal to U has been the biggest game changer this epidemic has ever seen in every aspect. And what does U is equal to U mean? It means, and this is actually equal to, undetectable is equal to untransmittable, which means a person living with HIV who takes the ART daily, who maintains a viral load which is suppressed, cannot, it's not a 0.2, 0.1, 0.001, it's a 0% risk of transmitting the infection. And we are not seeing this on paper. This came out in 2015. We are 11 years from this data. And we've all, as ID physician, HIV clinicians, we've seen this translate into our practice. That our discordant couples have been in unprotected relationships, and the person who is negative has remained negative. What led this U is equal to U? Okay, the landmark study was HPTN 052. I'm sorry I'm bringing in these studies because it's so important to tell you how old this data is. HPT and O52 started way back in 2005, and their results were such blockbuster results that they had to give an interim report in 2011. The final results came out in 2015, and when they saw the linked transmission, there were 0 linked transmissions with suppressed viral load. And subsequently, of course, we've had partner 1, partner 2. In all, we've seen over, and this is only until 2018. By now, we've seen over, only until then, we had 150,000 condomless acts, and there were 0 genetically linked transmission. So here, that partner who is negative has been in an unprotected relationship with a positive partner, has not acquired HIV. Where is anything else going to come to us as clinicians? Okay. So this gave the whole basis of what we call as treatment as prevention, where we are not talking about treatment for the patient. Here we are talking about treatment as a tool to prevent an ongoing transmission. And this was the most powerful thing that happened in the HIV management, is U is equal to U. And as soon as this happened, the guidelines changed. Okay? Now, if there was such an important reason to give ART, not just for the individual, but also for the partner, all the guidelines changed to giving ART based on CD4s. We discarded that, and we said every person who tests HIV positive needs to be on treatment. And therefore, if you see the last column, it all turned to all. That means irrespective of what the CD4 is, irrespective of where the viral load is, everyone receives treatment so that we get all of them to the undetectable viral load. And now this individual who has HIV is practically not going to transmit the infection to anyone forward. Not the partner, not the child, and definitely not the clinician. So we moved from this entire thing that we saw 3 decades ago, where a HIV positive person would eventually get AIDS and would eventually die. Death was out of question. Okay, we went back. Right from AIDS, if the patient started on treatment, we could bring him back to only being labeled HIV infected. But what happened was, they could get married and have babies, and still kept their partners negative and kept their children's negative. So now coming to our topic on HIV and pregnancy. We know this. There are antepartum factors, intrapartum factors, postpartum factors. The postpartum factor, of course, is the single one is breastfeeding, and I'm not going to enlist this because we all know about this. And this was the transmission rate that we knew in absence of interventions. So honestly, this table only holds true for someone who comes in without knowing their status of pregnancy, and we do not start treatment. So those are the values, and you will see that they are anywhere from 50 to 30%. Now, as science progressed, we started adding one intervention after the other. Okay, so the first thing was, if there was a postpartum factor that was in our hand, stop the breastfeeding. So as soon as we stopped the breastfeeding, we came down to 20%. Then came the first drug, zidovudine. As soon as we gave that one drug, we came down further, and then one drug plus no breastfeeding. Then we had 2 ARVs. Then we had 3 ARVs. And let's see what happened after that. So until then we had ARVs. We knew that if someone came with a detectable viral load, you just do a C-section, at least take away the intrapartum risk, avoid the breastfeeding, and give the neonate ARVs. What happened? There was a big study again in 2015 which showed that if it's a very detailed study, but I've really picked up the highlight of that study, is there was 0 transmission seen if the ARV was started before conception, if the ARV was continued through the pregnancy, and if the viral load at delivery was less than 50 copies. And this was U equal to U for the child. Okay, so if you see, in all practical scenarios, even if you say, oh, maybe there was someone who wasn't adherent, maybe the viral load went up a little bit, maybe we didn't monitor well, maybe the patient missed pills. Honestly, that doesn't happen. We've seen that with our pregnant patients. The one time that this lady will be absolutely adherent to treatment is during pregnancy, because now she's taking it not for herself, but for that baby that is going to be born. And this is the time she will not miss a single pill. So even in the worst case scenario, the transmission was only 0.2%. And if the lady came in the first trimester or the second trimester or the third trimester really late, and we missed for some reason during that period, then the risk went up. So the overall transmission rate across, if we did not pick up before pregnancy, and this was during pregnancy, then it was 0.7%. Earlier, the ARV initiation lowered the transmission risk. And what was key was adherence and viral load monitoring. And then there were several studies that spoke about early ARVs and sustained suppression and the continuity of care to virtually eliminate vertical HIV transmission. And that is where we will be able to achieve our goal of zero mother-to-child or elimination of mother-to-child transmission. Coming to a few other nuances that came out as highlights in this. Okay, the BHIVA guidelines clearly, I mean, they started that way back in 2018 and updated them in 2013. Vaginal delivery is recommended when the viral load is suppressed. The DHHS guidelines have no C-section required solely because a lady is HIV infected if she is suppressed. And overall, you will see that everyone over the period has become more and more confident, and we've seen that. So what I'm going to say now on is from guidelines across. Okay, BHIVA, WHO, DHHS and NACO. So a very practical setup. Okay, a lady comes to our clinic, we screened her. Some of them will come with an HIV. She'll tell you that I'm HIV infected, I'm on treatment. But maybe we are not in that scenario. We screen her. And when do we screen her? The first is at the first antenatal visit. And please make sure you see the report. Only last year, we had someone from a tier 2 town where she had the HIV positive report. Someone missed that report. And the only time that report was seen is when she went into labor and that report was seen. So make sure we see that report. Repeat, if you have a sense of this could be a high risk setting, definitely test the lady again in the third trimester, because you still have a chance of protecting if she acquired it during her pregnancy. If the lady turns up to you only in labor, test her in labor. And do not forget to test for hepatitis B, HCV and syphilis. We can't not only thinking about HIV, now we are talking about what we call triple elimination, where we eliminate HIV, syphilis and hepatitis B all at one go. So the lady tests positive and she's not on ART. What do we do? Our urgent goal is to put her on ART immediately. Okay, except for some contraindications that you will be able to discuss with in tandem with the physician who's going to treat, ruling out opportunistic infections and all of those things. But in this scenario, even with opportunistic infection, we understand that our urgency is to really protect that baby. So this is one scenario where we really want to do a same day ART start, because every week we lose is an added risk to the child. Okay, so regardless of the gestation, regardless of CD4, regardless of viral load, and regardless of all the baseline labs, because the drugs that we have are just so safe. If the patient is on ART, we breathe a sigh of relief. The most common regimen that most of our patients are on is TLD. It's a perfectly safe and an extremely effective regimen. All that we need to do is confirm whether the patient is on treatment, make sure she's on TLD, and continue if it's well tolerated. Definitely order the first viral load. You don't have to wait to send that patient to the physician. You as surgeons or gynecologists just order that first viral load, because that is what we want to see. Is she suppressed? If she is suppressed, then this is a breeze. Breeze for her, breeze for the child, breeze for us. Review the adherence. Don't forget again to screen for the other STI, and then you can do your routine antenatal test. Coming to ARVs in pregnancy, thankfully all our patients are now on TLD. Okay, so I put in that TAF there because tenofovir has 2 different molecules. In the private sector, we have both of them. In the public sector, we still have only TDF, which is fine. They're exactly the same for all practical purposes. The second regimen, TAF, emtricitabine and bictegravir, is also available in the private sector. Only 2 weeks back, at the CROI conference and in the guidelines last year, bictegravir has also been included as one of the drugs of preference for women who are pregnant and with HIV. The other two are regimens that are fine, okay, just that anyway for all practical purposes we move to TLD. Why TLD? Because dolutegravir is just such an amazing molecule, and we can tell you that after dolutegravir has come in, it's really changed HIV management. We know that once we start dolutegravir, there have been times when a pregnant lady has come in during pregnancy and we've actually checked her viral load immediately after a week and it comes down so rapidly. Okay, within a week we will see a 1 to 2 log decline. It's an extremely high resistance barrier, which means it is forgiving if the lady misses a pill or two. Of course, that's not we tell them, but we know that it's there. It's excellent pregnancy safety data and it is the endorsed molecule globally. A few things about dolutegravir or the regimen in general: do not give that with iron. You know, most of our women will be with iron. They are given at 2 different time points. And if they are on other hormonal drugs, there's an excellent Liverpool HIV drug interaction checker. We all use it as well, where you just, it's called HIV drug interaction. As soon as you put that on Google, there's a website that opens, you put in all the medicines that the lady is on, the person is on, and it gives you all the interactions. When do you monitor the viral load? The first viral load was done when the lady came in because we ordered it on the same day. Okay, if that is less than 50, we are very happy. If the lady was not suppressed and we've now either added the ART or now counseled her that please take your pills, you're now going to have a child, then you check the viral load 4 to 8 weeks after the ART to make sure that she's suppressed. And I said dolutegravir will bring the viral down quickly. And then we do it again at 36 weeks, because at 36 weeks is our decision point. At this point, we are going to decide whether this lady goes in for a normal delivery or is there a reason for her to take up for a C-section. Okay? Sometimes if there is something that happens in interim, then we might do a 28 week as well. But we definitely do the first, a 4 to 8 week after the ART start and a 36 week. And our target here is less than 50 copies. If viral load is less than 50 copies, boom, this goes clearly as any other patient. Vaginal delivery, no zidovudine required, staggered neonatal prophylaxis, which I will come to. Transmission risk honestly is 0% because you monitored the lady through the pregnancy. If she was on ART even before she conceived, then it's 100% zero transmission. Okay, and most importantly, there is no special PPE required. No separate plastic gowns, nothing is required. This can go as any other normal delivery. This is the patient who is safer than your patient who tested negative. Because your patient who tested negative might be in window period with a high viral load and you're thinking she's negative. This patient is proven positive with undetectable viral load. No way that she's going to do anything to you. This is the ideal patient you would have. If the viral load is above 1000 at 36 weeks, this is the lady that you will say, you need an elective C-section to even take away that little minute risk of transmission intrapartum. Okay? In the previous one, the neonate only requires a single drug ARV. In this scenario, the child will require 2 or 3 drug ARV. This is your time to tell her that please take your ARVs regularly, because even those additional 4-5 days of adherent ARV is still going to bring down the risk. And this is the time that you will have to work in tandem with the neonatologist to monitor the child to see if any disease was transmitted. So we do it at birth, at 6 weeks, at 6 months, and this is all PCR based. We never do antibodies in children because the maternal antibodies get transmitted to them and can linger around for even 18 months. And 6 weeks after cessation of prophylaxis, for a rare possibility that being on ARV suppressed the PCR and therefore you didn't pick it up, but that also doesn't usually happen. What is the intrapartum management? Continue the ARV, minimize the risk to the neonate or the fetus, so avoid anything invasive in terms of electrodes, unnecessary instrumentation, reduce the exposure time, avoid clamping the cord, milking the cord or delayed cord clamping. Coming to breastfeeding, WHO clearly says suppressed viral load, baby out, mother was on ARV through the pregnancy and delivery, the baby can be breastfed. Okay, and anyway we are going to be giving the baby single dose zidovudine. DHHS and Viva guidelines say it's a shared decision making depending on what happened during the pregnancy. Where was she diagnosed? When was the ARV initiated? How is she right now? But breastfeeding is safe. Where did this data come from? This one study, the PROMISE trial, is like a landmark study because it became the basis for a lot of global guidelines. Okay, it's a beautiful name, Promoting Maternal and Infant Survival Everywhere, PROMISE. It was a multi-country randomized control trial, a very real scenario trial, where they were pregnant women, they were breastfeeding women, and they were compared with a triple ART in pregnancy to a short course ARV, and they had different components that they checked for antepartum and postpartum. What were the highlights of the finding? Triple ARV, that anyway we are giving, we spoke about TLD, brought down the risk, extremely low postnatal transmission, no significant added benefit of an infant prophylaxis. Earlier, through the breastfeeding, we would give an infant prophylaxis. But if your mother is on treatment through breastfeeding, then the infant doesn't need any additional medication while the child is breastfeeding. The neonatal plan, what do? If the viral load is more than 50, at any point after the 20-week gestation period. If it was less than 50, then there is no or zero risk, and only thing required for the child is single drug, zidovudine, okay, for 2 weeks. If the viral load was above 50 at any point after 20 weeks, and did this viremia occur in the 4 weeks prior to delivery, so in the last 4 weeks, if there was, then this is a high risk for transmission, like someone who comes in very late or during delivery. In that case, we will do a 3-drug regimen for the child, and of course NAT testing. Now one thing about the drugs is we say it so easily, give 2 drug or 1 drug. None of these preparations are available as syrups. Okay, we only have tablets. And there are few pharmacies that we've identified across the city that will take the tablet and make 25 little pieces of that tablet, and that is what we need to administer the child. Okay, this is about NAT testing. I spoke about not forgetting STIs and partner testing. Very quickly, last few slides about PrEP and PEP. I know Lakshmi touched upon it. The post-exposure prophylaxis is, we can talk about it in the future, in the subsequent talks, but I wanted to talk to you about PrEP. PrEP is pre-exposure prophylaxis. So in a scenario where the husband is positive and with detectable viral load and the partner is negative or vice versa, we can still protect the partner until that partner becomes suppressed. Because once the partner becomes suppressed, we spoke about it, undetectable, untransmittable. That means we only need this bridge period of 2 to 3 months. During that period, we give what is called as PrEP. It's a single tablet of tenofovir and emtricitabine. Excellent efficacy shown across trials. There are other people who we give PrEP to, people who have multiple sexual partners, men who have sex with men. But in this scenario, we are really talking about a serodiscordant couple. Coming to the law, this is what I was telling you, that there is a law to protect us. In 2017, the government of India passed a bill called the HIV/AIDS Act 2017, which clearly says, and I will read it out as is, the bill defines what can account as discrimination against HIV positive people and people living with it. It lists that denial or discontinuation of healthcare services, and also it prohibits HIV testing being used as a prerequisite for accessing healthcare. And that is a very strong statement. They're not just doing it for a law. There is a lot of science to back it. Therefore, all countries have done away with triple H testing. It's not required anymore. It's an opt-in testing, where if required, you will do it, and not a universal testing for everyone. Because there is no risk to us. The only reason why we should be testing triple H today, the only reason, is to identify who's positive and connect that person to care. and not for us, because that person is never going to be a risk to us. So mandatory consent, pre-test and post-test is required. No mandatory HIV testing can be imposed to provide health care, and we have to extend the same care, the same support that we would to an HIV uninfected person. This is something that we really aim for. Maldives, such a small country, with a lot of support from countries like India, triple elimination of HIV, Hep B and syphilis. 20 other countries have eliminated mother-to-child transmission. We provide 90% of the drugs to the rest of the country. I think together we can bring India on that list, and I really hope we can do it together. With this, I would like to end my talk. Thank you so much.
Thank you, Trupti. And I see in you the same passion and fire that I had witnessed about 35 years ago with the same Gilada legacy.
Thank you so much.
Proud of the family.
Thank you.
I can visualize Ishwar there, who was, the legacy that the family has of leading the forefront of India's response, if I might say, to HIV, the community advocacy that the family had. And I remember as a young girl of about probably 8 or 10, would move around with us bandwagon in those days, trying to influence everybody to take on the infection, to take on the virus. I remember distinctly we met a politician right in a hotel, and here Ishwar was trying to convince him about policy, and it did happen.
Was it
At least, sorry?
Was it Sunil that?
No, it was a Congress minister. But it did happen. The national program took over in, I think, 2000, 2003, and there has been no looking back. It's the 5th phase going on, and I'm so proud of it all.
Thank you.
Yeah, open for questions. I think that should be a lot of.
Does the government give free medication to the pregnant women who are from a municipal hospital or something like that?
The government gives free medication to everyone. Everyone.
1.7.
Anyone who lands in the ART center is given free ART for the entire
Which
lifetime.
hospital we are looking at?
See,
All
let
hospitals.
me just add, so the early infant diagnosis is the program which was launched by NACO in 2010. Okay, when we talk of early infant diagnosis, it is DNA PCR for identification in the newborn. And at that point in time, when we started the early infant diagnosis using DNA PCR, mother was not put on ART. The prevalence was high, and DNA PCR was done free of cost in our own lab at Kasturba. So government is giving free testing. The game changer, of course, was in 2015 when the antenatal mother was also put on ART, and 2 tests, 2 DNA PCR tests are also done free of cost. So when you talk of free of cost, the government program is very streamlined, right from diagnosis to treatment.
I think today is the time that, if you have an HIV positive lady and her partner, the best thing a private practitioner can do probably is to link her to a specialist or to the ITCT centers of a public hospital. Because once the government takes it over, believe you me, it's fantastic. Right from her being taken care of, the counselors are in Varia we did that. We were doing that now. Earlier we were so-called pioneers of it. But once the government program took over, it took over in a very big way. And that's what at least our enthusiasm wants, that just like we had family planning program, just like we have a polio program, there should be an HIV program. And I think succeeded in that. And once that happened, linkage to an ITCT center, an ART center in the government enterprise or in private practice to a specialist would take care of it. I think that's the key to it. Because it covers right into all co-infections and comorbidities also, subsequently.
Trupti, that was brilliant. I had a question. If the maternal viral load is less than 50, That means she's not able to transmit infection. Why does the neonate still then require prophylaxis?
I think just because they're not confident to not give it yet.
Yeah. I'll tell.
And because a lot of these data is from clinical trial setups, and the real life might have some plus and minus. So to even take away that little risk for that little one, we give that single drug.
Trupti,
And
can
that
I
was
answer
only
this
for 2
question?
weeks.
Can I answer this question? So Vinita, the issue here is that the antenatal mother, when she presents to the hospital, that is the time we are doing the testing and diagnosis. Suppose she is HIV positive, okay? Now we don't know at what stage has she come at, 16 weeks, or she's come at 20 weeks, or whichever, okay? Now, there is always a possibility of the viral load increasing. We are not testing that woman again at 36 weeks. That's not happening. So there is a possibility.
We are,
Even in the public hospital,
we are
not doing testing.
We are. Oh, we are testing.
Then it must have changed. But there is always a possibility of a new infection, or due to non-adherence, viral loads can go up. So it is better to give the prophylaxis.
Can you just put down the slide for 1 minute? I'll also.
This is all old data.
Yeah.
The whole giving post.
So this is what I want.
Natal.
Sorry.
Postnatal prophylaxis was the concept came about because the max transmission took place in labor.
Yes.
So when it took place in labor, you had to cover up that period, especially even if there was a known breastfeeding population. So even if she did not breastfeed, we had to cover the first few weeks. And that is why we gave this first few weeks of Zidovudin in the earlier days, and now subsequently never. Yeah. Now it's never been the first choice. And you could get dual also with the high viral load. So all that.
So the one thing is that the ideal setup is if we diagnosed her before conception, was suppressed, and that would be 0%. But because the lady might be anywhere here, diagnosed here, or here, and then that risk is still there, that's why they are. And we take care of that.
And one more question I wanted to ask: when somebody in a discordant couple is on pre-exposure prophylaxis, practically speaking, how many of those ladies have side effects of being on prophylaxis?
They're very safe medications. Tenofovir and emtricitabine are extremely safe. Except for some gastritis on the first few days, there's nothing else.
Two difficult questions. Marketing gimmicks by the Ayurvedic doctors and everything, converting an HIV positive to HIV negative. I'm just. And then, madam, what is the role of RNA-PCR? Now, let me ask you a very simple question. I have a patient coming to me as a sperm donor, okay? And the requirement is now. Means normally we have a quarantine period of 6 months and doing the test again and then giving away the sample. But if I have to give the sample now, then is there a role of doing HIV RNA virus testing so that, or any other testing to know whether it's infective or is in the window period?
That is the nucleic acid amplification test, the NAD-based test.
So he's asking for an RNA PCR.
That's viral load.
Yeah, so basically what he means to ask, what I understand,
whether it is in the window period or no?
Like in which sample? You're talking about a blood?
Semen sample.
No, semen sample. He's talking semen sample.
Okay.
He's a semen donor.
Yeah.
And you want to know. So he's HIV negative, I presume.
Can we release the sample earlier is what Kedar is asking.
So the limit of detection of an Abbott system which we use for RNA PCR is 40 copies. Okay. So if he has 40 copies, then will be detectable. Here again there is a risk if he has less than 40 copies. So the limit of detection is 40 copies.
No, are we advocating them to do
That's
an
what-
RNA PCR for a
No, he's...
Kedar is asking, can we release the sample before the
I mean, if he is not a high-risk person,
No.
and you have an...
He's talking about a sperm donor whose sample is stored. Can we release it in an emergency?
In an emergency case, that is what it is.
If you have a test of a 4th generation ELISA which has P24 antigen plus the antibody, I think that is the first few would be about
No,
positive
but Dr.
within.
Kaizad, P24 antigen comes only 16 days after
Yeah,
infection.
14 to 16 days.
Even if he has resources and the patient is willing to pay, then doing an RNA PCR is a good option if the patient is willing to pay. But that also comes positive after 6 days and the limit of detection of the test is 40. So you have to keep all these variables in mind when you requisition a test.
Any other questions? Can I ask a purely selfish question as a clinician? Trupti, can I ask a selfish question as a clinician? If I'm operating and I get a needle prick, what is the chance that I will get HIV, that I will get HBsAg, I will get HCV?
Very simple. If the patient is virally suppressed, your chance of HIV is near zero. Take TLD to feel good.
And if she's not virally suppressed?
She's not virally suppressed, you take TLD.
Chance of
Nothing. Once you take TLD is zero. Once you take your PP, it's zero.
On the other
Hepatitis B, if you're vaccinated, you will not get it. If you're not vaccinated, you should take it today.
Okay. Otherwise, what is the risk of me getting it?
Very high, 30%.
Okay.
Yeah.
HCV?
HCV is a good virus. There is nothing, there is no PEP, there is no vaccine. But if we end up getting it, it is completely curable. Completely curable in 6 weeks. Completely curable. So that means triple H testing is not required.
It's a blab.
You are saying now Triple H is not required.
We'll call Metropolis only.
Irrespective of anything, if you get a prick, that means you have to take ART.
No, then you test.
Then you test. That is when you test. That is what every entrant.
You don't sleep
so
for
Dr.
24
Sankpal,
hours.
No.
Dr. Sankpal, we are the only country who is doing triple H. I'm just telling you, there is a reason why everyone else has done away with it. You test if you get a prick. If you don't get a prick, you don't need to test.
And if,
Sorry,
if
they've been ringing
you
the
test,
phone. Sorry.
and if she comes negative, can she be in the window period?
Yes.
So a lot of this is history. You know,
the time.
it's lot of it is history.
So it's
History
better
taking.
to
It's a
take.
60-year-old lady. What window period will she be in? Like we have to take all of these things into consideration. You know, it's not. It's a case by case thing. We can't make blanket guidelines like
No,
this.
no, I am talking about suppose by chance anybody gets sick, the side effects of ART for
No,
28
TLD
is
is
not much.
TLD
No?
is super safe. No side effects. The older ARTs did, but not anymore.
So that test RNA PCR costs how much?
3,000.
1 minute, you are saying there are no side effects?
No.
Then you are imagining them?
When did you take it?
Long ago.
Those did, not anymore.
Not the current.
Not the current ones.
Yeah, I don't have a question. Excellent debate and lovely points to be interacting and putting brainstorming all these things. What I just wanted to say for the clearer understanding of everybody in the audience is, in the government program, a viral load is done for all pregnant women between 32 to 36 weeks of gestation. A repeat HIV testing is generally not recommended if she is initially tested negative, unless you find some kind of an risk factor where you think, oh no, we need to retest this lady. Otherwise, that's not really a part of the mandate. So viral load testing is done, and if the mother is found to have an unsuppressed viral load, anything above 1,000 copies, then the baby goes on dual prophylaxis, which is nevirapine and zidovudin soon after birth, and that is continued for 6 weeks if the mother is going to breastfeed the baby. And if she is going to be a high viral load and breastfeeding, then we give her an extended prophylaxis for 12 weeks. If the mother between 32 to 36 weeks of gestation is found to be very well virologically suppressed, then the baby goes on just a single drug, which is nevirapine, which is continued for 6 weeks, irrespective of whether she's going to give breast milk or exclusive replacement feeding. And the baby is sent for the EID cascade, which starts off at 6 weeks. The first testing of the baby goes at 6 weeks, and if that comes positive, then the baby, a repeat sample is sent and the baby is started on ART. It's just a clear understanding.
Thank you so much. Thank you, Mamatha.
Just one question. For discordance, would you recommend on-demand PrEP or a regular PrEP, continuous drop?
Depends on which situation.
No. Continuous PrEP. In a serodiscordant couple, it will be a continuous PrEP until the partner suppresses.
Demand PrEP is usually given when it is MSMs and they are planning to have unprotected sexual contact, then you give it for 5 doses over 2 days. That's on demand PrEP. But for a discordant couple, it's continuous with the mother.
Can I have just one suggestion?
Just one more.
As a society, can you come out with a policy statement that HHH testing is not necessary? It will become so much easier for us to argue with our hospitals.
Yes. Point.
Not a white paper.
White paper.
It's important, we are also, it's not the question we are fighting, it's a two broad organizations are coming together to discuss something. It's a good point. Our ideas as a practicing physician and surgeons that we do HIV for every patient. HIV triple H, it's our routine practice. And we do take consent for that, for the patient. And it's, so many things will, be safeguarded.
I think we are running behind time.
Thank you, madam. We'll go ahead.
We have to finish.
Antenatally, patient comes to me at 8 weeks, I do HIV, is negative. The recommendations, I don't repeat the HIV again.
Till 36.
Unless you have a reason to believe the recommendation.
She's in window period or something like that. Do you have any?
We repeat it. Actually,
So you also test the partner.
Yeah.
So if the partner is negative,
During pregnancy, where we take the partner? We don't take.
we should.
We don't.
But we should.
She's negative. She's negative.
Madam, in the public system, are you testing the partner?
No.
If she's
No,
negative,
we are testing
No,
only
you are, no?
No.
Yes, I know that. Yeah, they asked the public.
All antenatal patients are tested.
Sir, sorry, I'm getting off here because they've been telling me they're really late.
Move forward, but let me tell you practically, we can't ask if the wife is negative and she's already been pregnant, and we don't ask the husband to test for his.
Sir, ma'am, can I ask one question is post-exposure prophylaxis available in the private sector for the surgeons and gynecologists? It is. Everybody is in.
An hour. There's no problem. It's just TLD, 1 tablet a day for 28 days. Really, very easily available. Ideally, in policy-wise, every hospital should keep it. You should have a policy and the drugs.
For giving the baby never-happen prophylaxis or zero-body never-happen prophylaxis, when we say immediately after delivery, how immediate is immediate?
Within 72 hours, but we started
within the hour.
Within
as early as
within
possible.
4 hours we started.
Sometimes you may have cases where the mother has delivered in a non-institutional setting and she comes to you with a baby who is 4 days old, 5 days old. Start. When you realize that the mother is positive, you do a test and if she's found to be positive, start the baby immediately.
And where will it be available in case you're delivering it in a private hospital? I delivered a baby and then I had
Not
to
available.
for the never-happen.
No, it's not.
They voluntarily gave.
I don't know, there seems to be a little bit of restriction of nevirapine, but
There was a NACO middleman who came and told me that I will give it to you. Then there was an exorbitant charge in the middle. I said, this is
I don't know. But we give nevirapine syrup free of cost. We keep a huge stock at Asha Foundation. If you want me to send it intrastate also, I can do it for you.
Ladies and gentlemen,
Sorry, we'll just
apologies, we are already running 1 hour
1
behind.
hour late.
So, I'd like to call upon Dr. Mathai to kindly hand over a small token of love
Thank you
to the chairpersons and of course the speaker herself.
Not the speaker, the chairperson.
Dr. Mathai.
Move on to the next one. Who's the next? Our next speaker is Dr. Poongulali from Chennai. A very unique combination of a gynaec, HIV, STI physician and a psychologist and practicing all three. And the chairpersons are Dr. Sukhwinder Kaur. She isn't here today. Dr. Glory, you want to chair. Dr. Sukhwinder Kaur and Dr. Nandita both aren't here.
ASICON and MOGS welcomes Dr. S. Poongulali, a respected clinician from Chennai. She plays a pivotal role in advancing comprehensive HIV care for women, with a special focus on the evolving health needs of women aging with HIV. Today, she speaks on caring for aging women with HIV.
Good morning, everyone. Thank you, Trupti. Thank you, Dr. Glory. And happy very International Women's Day to all the esteemed women colleagues in this room and to all the family members of the esteemed men colleagues in this room as well. So thank you for having me today. So amidst all this hullabulla about the ART in pregnancy and doing triple H or not, I come with this totally different bouquet of flowers, caring for aging women with HIV. So in short course of years, this treating HIV, don't take too much of this pregnancy because in short course of time, women with HIV will be in pregnancy, it's going to be very low. All of them are going to be, most of them at least are going to be on ART, they are going to be virally suppressed, and they are not going to transmit the infection to the baby. The real big success story of HIV has been prevention of vertical transmission of from mother to child. And I think, you said, sir, the availability of nevirapine in a privately delivering patient is still a challenge. And I would like to request Dr. Glory to give me a supply of nevirapine as well, because every time we have a patient who is booked with us, we have difficulty in acquiring nevirapine for the baby. So all women age, study says aging starts around roughly 20 to 25 years. If those who are younger are happier, and I'm happy about the AI because it really made me look many years younger. I couldn't recognize myself. So there's one now. Agatha Christie is one of my favorite novelists, crime thriller, and she was married to an archaeologist, interestingly. So once in a course of an interview when she was married, they asked her, how does it feel to be an archaeologist's wife? So she said, it's actually very exciting because the older you go, the more interested he is in you. So we know all over the world, especially in countries like India and some of the other Asian countries, we have lots of these population control policies that came in some years back. And now the WHO says that at least 1.2 billion women will be menopausal or postmenopausal, essentially as a marker for they will be aging by 2030. So in India, at least 15% of women, as per the national statistics, are in the postmenopausal state. Some in very early menopause because of surgical menopause, which was surgeries which were done very earlier. And so like women without HIV, I think one thing I would like to say that we have actually moved away from calling women HIV infected or HIV positive to say women with HIV, women without HIV, people with HIV, people without HIV. So women with HIV will be living most part of their life as postmenopausal, or they will be aging and they will have to go through the whole gamut of the changes that any other woman with aging will have to go through. So what makes it important that we discuss or learn about preparing for this talk has been a big learning process for myself. I'm preparing, I'm sure you all will know, getting ready for any talk is a big learning process. So women actually are disproportionately affected by the changes that aging produces in women who live with HIV. And they have a higher risk of osteoporosis and cognitive decline. This is very important because compared to men, these women seem to, compared to the other part of the geriatric syndrome, women seem to be at an increased risk of osteoporosis and cognitive decline, actually predisposed because of, attenuated because of their because of the menopausal transmission and because of the drugs that they take for their antiretroviral therapy. This is a beautiful picture because it puts into context what are the changes that happen in these women. They have two modifying factors. If you look at one side, those are the HIV-related factors, which could be because of the chronicity of the HIV infection itself. HIV can cause, HIV is an inflammatory infection and it can cause chronic inflammation. And because of this infection, they can undergo all these changes that you see on one side, the HIV-related contributor. On the other side, unique to women, mostly unique to women. Men undergo andropause as well, but usually unique to women. you see the very aggravated changes of the sex-specific contributors, which are because of the menopause-related ovarian aging, sex hormones, and the chromosomal anti. So we all know estrogen is a superstar hormone. We know estrogen is cardioprotective, estrogen protects the bone, estrogen does this, estrogen does this, estrogen does multiple things. So, but what is very important and what is very commonly not discussed is the sex differences in immunity are present, and these are mostly estrogen modulated. Estrogen is anti-inflammatory in a premenopausal woman. Estrogen alters the pattern of inflammation in women who are premenopausal, as opposed to women who are postmenopausal who have estrogen withdrawal and depletion, causing more inflammation in that group of women. This is a very landmark study which was done by Dr. Epstein, and she published in this how actually through the different age groups, not to go into big details, just to say that the pattern of in immunity are different in men and women, especially in women in the postmenopausal age, mostly modulated by estrogen. And this in particular contributes to the changes in women that we change as they age, mostly because actually compounded by the fact that they have an estrogen withdrawal that accompanies their aging process. So this is in a nutshell to say what estrogen depletion can do. Estrogen not only alters things in the body, like it withdraws the cardioprotective, alters lipids and so many other things, but it can also cause gut permeability, increase immune activation, and very importantly, it can increase HIV replication. So we all know when HIV infection occurs, there is some sort of part of the HIV that goes into the reservoirs. So these reservoirs might be in various places, which is actually a challenging cure. So these are where the latent virus is. And what estrogen does is, estrogen, due to its multiple pathways, make sure that this reservoir is smaller in women. But postmenopausal women or in aging women, you will say that the dynamics of this reservoir change, especially because of the estrogen withdrawal. This reservoir seems to expand in women who are postmenopausal or who are aging. So these can actually challenge the efforts and cure that we are, and research that is happening, because now there are lots of demand that cure studies be customized for women. You can't do general cure studies for men and women and say this will act in both. It cannot happen because the dynamics of these reservoirs are different in men and women, mostly estrogen modulated. So then there's a big conundrum. When does actually, because when we speak of HIV, we keep speaking of accelerated aging, we say aging happens earlier, menopause happens, because we've always been taught menopause happens earlier in women with HIV. So is that the case? The study set out to find. So what they actually did is, because what they found out actually is, we realized that through the course of years, what actually the information for age and menopause came from self-reports. So in this particular study, they took a group of women without HIV, a group of women with HIV, and they did self-report of amenorrhea, because you all know secondary amenorrhea is very common in women with HIV. So they took a self-report and they matched it with the FSH reports. So in this, if you look at the diagram, you would clearly say that there is not a big difference in the age of menopause in women with and without HIV. But interestingly, in both groups, earlier menopause occurred in women who had other co-infection, had a history of smoking and some or other risk factors, but this was common to both the groups of women. So then one group thought, okay, we are seeing some changes and there seems to be some difference in aging between these two groups. So what can it be modulated by? So they thought probably we should look at reproductive aging as a marker of menopause in this group of women, rather than looking at the age of actual menopause itself. So here they use AMH as the marker for reproductive aging. So they had one group with normal AMH, normal menses. They had one group with low AMH and lower absent menses, and they have this middle group you will see with regular menses, but they had very low AMH. So this they took as a marker of reproductive aging or actual premenopause. And in this study, they found that the approximate age of menopause was like 49 years in this group. This was from a group of women in a study called RIPRI, which is recruited across the country, and they were like 7,300 men and women who were followed up for more than 7 years. So if you look at this, it looks like reproductive aging starts a little earlier, maybe around 49 compared to the 52 or 53 that we see in practice. So what actually happens with menopause? So like in any other woman who undergoes menopause, women with HIV also undergo this whole gamut of symptoms. But what is interesting and what is important that we notice, they had more severe symptoms as compared to women without HIV. When they had symptoms, they had very severe symptoms. At least 1 in 5 of women with HIV definitely had symptoms, and they had very severe symptoms. And very importantly, mostly they were not addressed. Because if you look at a woman living with HIV or a woman with HIV, the main focus is on treating the HIV per se. So even in a practice where everything was treated, there was not much focus on menstruation or menopause or aging related things. So this is why it should be incorporated, and we feel it is important that we talk this to a group of obstetricians and gynecologists who are at the mostly treated as primary care physicians for women across generations, not for one generation. I've seen obstetricians deliver mothers, daughters, granddaughters, and so on and so forth. So what actually should we do? One is we should address that these women are undergoing menopause, because perimenopausal and symptoms, vasomotor symptoms and body pain symptoms can actually start off earlier in these women. So it is important we advise proper lifestyle. And most importantly, what I want to stress is that we need to do personalized hormone replacement therapy. Because there is a huge misunderstanding that hormone replacement therapy is probably not for this group of women because of the let's say assumed interaction between the drug. Just like Dr. Lakshmi said, just like for the OCPs, with the newer drugs there is not much interaction. And menstrual hormone replacement, menopausal hormone replacement therapy is the standard of care for vasomotor symptoms, and other symptoms happen in these postmenopausal women with HIV. So this was an interesting recent RCT which was published a month back. So here they took a group of women. So they took a group of women who they had two groups. They were trying to see whether estrogen, vaginal application of estrogen will cause any change in the vaginal symptoms and also the microbiota, because now dysbiosis is an issue that is coming as a precursor for multiple things. So this was two groups of randomized women. One group got the vaginal estrogen, another group did not get the vaginal estrogen. So they found that though there was not a big difference in the microbiota and all that, they did found that there was a great resolution and improvement in the vaginal symptoms in those women who received the vaginal estrogen. Just to reiterate the point that menopausal hormonal therapy is indicated and should be the standard of care for women who come with menopause related symptoms. And this particular trial is currently enrolling. They are trying to look at transdermal estrogen and progesterone for vasomotor symptoms in women with HIV. And also when we say HIV, though we try to focus more on the menopause, HIV and aging is not only menopause in the women, it is also the whole gamut of so many other things. It means ART, it means all the other aging things that men without this actual conundrum of menopause and women without HIV undergo. So this, we all know that today HIV is a chronic manageable disease. It is not a death sentence or a terminal illness. It was 30 years back. And we know women with HIV are living today with modern medicine and newer drugs and regular care and viral suppression. We know that people with HIV has the same life expectancy as people without HIV. So today, if you look at this, you will see that the lower bar is actually the group of people who are actually dying because of AIDS, which was a big thing in the past. Today, you have only people dying more. You see the other groups of mortality increasing in this, especially the non-AIDS associated malignancies, the diabetes, the CVDs in other groups. You will see the AIDS related. This is the miracle that the ART has brought in. But we should remember, as this cohort is growing, as these people are growing older, and there are interaction of multiple things, we will see that other comorbidities are becoming increasing in this group. So what I actually wanted, I know when we look at comorbidities in any group, especially in a country like India, there are so many things. There are cardiovascular, we know HIV, especially in women associated with the increased risk of subclinical atherosclerosis. Women with HIV are undertreated for cardiovascular illnesses. and other things. And we know it causes so many other problems. Metabolic issues are there. Diabetes is India's kind of the diabetes capital of the world. Diabetes is a serious issue in a country like India. But there are two things I actually wanted to focus on. One is cognition, because these are the two important things that women with HIV are badly affected by in the course of aging. So here what happened is they found there seems to be a little accelerated process in these group of people. There is accelerated aging. It is kind of the decline in cognition is premature. It is accelerated and accentuated, which just means that it is worse than it happens in any other person. It happens quicker. It happens more. It is bad, and it happens very. They are very severely affected. And what is more important is that unless you really look for it and screen for it, you can miss it before it is actually treatable. And also very importantly, it is affected by two main, it seems to be modulated by two main things. One is the legacy effects of HIV, which is like if they are probably living with HIV for many years, probably the inflammation and so many changes that the HIV infection itself has caused, or ongoing viremia. Ongoing viremia is a risk factor for so many things, and likewise ongoing viremia can be a risk factor for increased cognitive decline. And also what actually adds to decline this cognitive issues in these women is factors associated with mental health. So two important factors associated with mental health is one is psychosocial indices, which actually happened in the past, not even recent events. So we know people with HIV or people with any other chronic infection actually have a higher incidence or higher prevalence of depression, anxiety, sleep disorders, and so on and so forth. But what is unique to this group is women is internalized stigma. So this definitely affects cognitive function amongst older women with HIV. So what is internalized stigma is that one is the stigma they are not able to share with anyone. Especially important in the aging cohort because of the loneliness and the social isolation. There is one very interesting and very sad term that I came across when I was preparing for this. It's called the violence of invisibility. The aging population, especially the women, are kind of invisible in any system, in a healthcare system, in a home or anywhere they're invisible. And it is a kind of violence on them. And going on with the bone, because the bone is the most important thing that we see women are affected by. So we know menopause affects the bone, we know metabolic changes affect the bone, HIV infection affects the bone, and most importantly, tenofovir is a wonderful drug. Tenofovir affects the bone. So in a aging woman, the government program offers only tenofovir because tenofovir is a good drug, no doubt about it. But when it comes to the bone, tenofovir has definitely been shown to have changes in bone mineral density, especially at the hip and the spine. And it given on the long run, it can lead to severe osteoporosis. So drugs like TAF, or today there are two drug molecules which do not have this NRTA component. They are only lamivudine and dolutegravir. So these drugs can help preventing these toxicities that are associated with tenofovir. So women have higher risk of fractures, but they have the takeaway is that they should be monitored, and if they are at risk, better to, especially elder women with HIV, better to put them on non-tenofovir based regimen. Frailty is more common in women. The type of manifestations or what symptoms that you see in women are different from that in men. So frailty is another one that we will see. It is pathologically, it is understudied. We do not really know how many of our women are frail, or how many, even going for how many of our men are frail, we actually do not know. Polypharmacy is another problem, because all these are now, if they have other comorbidities, then they have to continue, they have to take the ART and they have to take the medicines for diabetes. This is where studies found that women are more frequently on statins than men. But I think what we have to do is we have to sit with the other providers. Like earlier said, HIV today is not only an infectious diseases person's prerogative. It has to be treated by a multidisciplinary specialist who have to sit together. Otherwise, sometimes you will see women taking multiple drugs. There will be like 5 multivitamins, 2 calciums, and so many things, because there is no coordination between all the other specialists. So I think one important takeaway from that is we minimize, and when we can, wherever we can give long-acting drugs or wherever we can put them on the lesser number of drugs or combinations, I think we should not hold on and we should go forth with that. So like I said, tenofovir is not a good drug to give in this group. TAF might be better. And all these are the newer drugs, and even the long-acting injectables which are common might be safer for this group of women. So going on, there are so many other things that I can keep talking about aging, but there is one concept called successful aging. So why should everybody have a bad aging experience? So there are people who have had positive or successful aging as they assess by themselves. So this is a very interesting study where they grouped women into two. So they assessed their aging by themselves. So they found that, so they had two components. One was the distress and the eustress. So they found that people who had positive attributes, so they underwent a successful aging process as compared to women who did not have these positive attributes. So the more anxiety, or it all finally comes down to mental health as well. So the more underlying problems which are not identified and treated, the more unsuccessful or difficult their aging will be, especially when it is complicated by multiple other comorbidities. So therapeutics, we all don't want, nobody wants to age, right? Everybody wants to remain young. When we look at somebody, yesterday we were discussing with Dr. Glory how Wahida Rahman has aged so beautifully. But actually we don't want to age, everyone wants to remain young. So anybody says, so I have a granddaughter who's 2 years old. So somebody comes, some of my classmates have very small children. So they come and tell me, oh, you are a grandmother. So I tell them, don't tell me I'm a grandmother. I have a granddaughter, but I am not a grandmother. So these are some of the drugs that have been studied in therapeutics for HIV infection to see, because HIV, aging in HIV is rather compounded. It is not as simple as that happens, and there are multiple other social factors in this. And also this is going to be the first anti-aging trial. So they have 4 different groups where they're going to randomize aging people with HIV who will be randomized to these 4 different groups. I'm going to finish. So these 4 different groups, and if you look at this, exercise is going to be a very important part, and we all know that exercise is a very important part of aging, and especially weight-bearing weights exercises as opposed to only cardio exercises or the regular walking, that is very good. But I think we also need to emphasize on our women that we need to do all kinds of exercises early on, not very late once sarcopenia and doing exercises will become difficult. So this is going to be a trial. So please watch out for the results for this trial. And this is the recommendations. Please do annual menstrual assessment even if they are not symptomatic. Also look for any mental health factors that might be because of partner violence, or also discuss with the ID physicians if you think there is a morbidity, to see that they are on the optimum regimen. Also, most importantly, please ascertain the contraceptive need. So there are 2 groups of women who are aging. One is those who have lived with HIV for many years. The other group of women acquired HIV only after they are 50 years old, because they had some risk factors. So I think when we treat a woman, we should not assume that if they are 50 plus, they will not be sexually active, they will not have this, they will not have this. So we should keep in mind that all these things are happening, because there's one speaker once interestingly said, we believe that 2 groups of people do not have sex. One is our children, the other is our parents. So that's how biased we are against sex. So I think we should remember that we look at a person as a whole, whatever age, because some studies have shown in some populations, even women at 80 are still sexually active. And menstrual hormonal therapies, menopausal hormonal therapy is definitely indicated and must be a standard of treatment in these women. And also, this is just, I don't want to say this to this group. And what I just want to emphasize is, if they are more than aged 40, please start statins. Because in this study where we looked, Chennai was one of our site was one of the partners in this trial. When we looked at men and women above 40 who had low or moderate risk for cardiovascular events, statin as preventive therapy reduced these events to up to 36% in this group. So statins are recommended as preventive therapy in this group.
You're running out of time.
I'm done. So in this group, so please do not hesitate. Multiple studies to show that statins are actually safe. So please start statins if you see a woman with after 40 with HIV. And this is an interesting slide. I just want this to be my takeaway slide. So there will be a suit of so it emphasizes that exercise is the most important thing. Exercise, not the traditional walking in the park, not the traditional exercises that we recommend, the real hardcore exercises that I think we should be promoting and advising our women to do this at a very young age. Thank you.
Good morning, everyone, and first of all, apologies to all of you. So, because today morning I was able to just come in, and nothing to do with AG. I'll not admit that because I just went to the other hotel, and so this was all the hiccup. So I'm very happy to be a part of this August gathering, and if we talk about, and I represent Jhpiego over here, you all have heard about it. So we work very closely, and I also wanted to show you the symbol which we carry as Jhpiego. It's a John Hopkins Consortium affiliate, and we are working in India since the past 2 decades. So the symbol, I would like to show it at the end. So, and secondly, coming to this topic, madam, you have nicely covered, all the aspects touching the women living with HIV and the aging. But there are 3-4 questions which are coming to my mind, because we work very closely with the national government, National AIDS Control Organization at the national level and at the states also. So I'll just talk more from the epidemiological, programmatic, clinical, and also what needs to be done ahead. So as we know that we have made great progress out of 40.8 million PLHIV, we represent 53% are the women and adolescent girls. But it's very heartening to, it is very sad to say that every week 4,000 adolescent women and girls are infected by HIV worldwide, globally. And out of that, 3,300 are in sub-Saharan African countries. So this is the broader picture. Now coming back to India, and when I talked about the 4 questions, so the first one is how demographic, yes? Yeah. So you have categorized it, one, how the demography is going. Second is all the clinical factors which are impacting, and very beautifully covered the cardiovascular, cervical cancer, all are contributing to it. But the third and important factor which you also touched upon is the stigma. I think in the morning Dr. Srikala was also touching on that almost in UNAIDS study for India also says that 30% of the women are having the load of stigma and all the other vulnerabilities. So that has also come out very well. But the last point which you were talking about, the evidence and what more needs to be done. So apart from, I would say, all the studies which are very much important, learning from your presentation, I would say that DEXA screening, which needs to be a part of the ART guidelines at the central level, are very important. And also embedding the menopause related. I don't see that is a mention at the guidelines also. So all this evidence which you have generated, I think that could be a show path for our national level interventions which are happening at India. So Madam was saying that I have short of time, so otherwise I would like to throw light on all the other details also. Thank you.
Thank you. So at the end of the session, if there's time, you can take some time and talk about it. So thank you very much, Dr. Poongulali. We'll go on to the, thank you, Dr. Sukhwinder. We'll go on to the next session. Dr. Mamatha is here. Dr. Srikala Acharya, you're here. Dr. Vijay Karanjakar. Oh, sorry. Just like to hand over a memento to the speaker. And the memento to the chairperson of the session, Sukhwinder.
Can we have you back on the stage?
Can we have you back? Dr. Vijay Karanjakar is it?
Yeah.
Okay, so, and Dr. Padmaja? Manavi Padmaja. Yeah, okay, fine. So, we'll go on. We need 5 chairs. Yeah.
Because there's no problem. Yeah.
No,
Put
not
the
the
light
lights.
on.
Only 5, yes. I would request Dr. Mamatha, Dr. Srikala, Dr. Vijay Karanjakar and Dr. Padmaja to please come on stage. So, welcome to this panel discussion, and it's got a very interesting title, The Woman, Not Just the Virus. Today being International Women's Day, I'm very glad that we were able to bring this topic to the forefront, where we are going to talk about the woman, and not just the virus, but also about the woman who harbors the virus. And before we start, I just want to say that saying HIV positive woman is actually stigmatizing. So we need to change our terminology and say women living with HIV. So that is something that people like us who've been working in the field of HIV, we've been saying that for years now. But it gives a better sense of familiarity when you say women living with HIV. Okay, today 45 years into the epidemic, we all know that there's been so much of progress in the field of HIV. We've been able to identify the virus, we can decode its replication, we can suppress the viral load. Women and men can live a normal span of life because of the advent of ART. So today we look at HIV not as a fatal, life-threatening illness, but as a chronic, manageable illness. But sometimes we have to ask the question that in our enthusiasm to control the virus, have we sometimes overlooked the woman? You know, because she's the one who's, especially in India, she's the one who's bearing the brunt of this infection. So when we look at it in India, 44% of women infected, in the HIV population in India, 44% of them are women. And do we know how women in India get the infection?
It's from the husband or partner, mostly.
Yeah. You know, there was a study which came out in 2015 which described this very beautifully. 90% of the women in India living with HIV have got it from their husbands. They have been monogamous. They have no risk factor. For them, the risk factor has been marriage or their sexual partner. So that is something that we have to keep in mind when we look at this. And also remember that many times, when especially now because of pregnancy, it's very important for us to do the HIV testing in pregnancy because we can protect the child from acquiring the infection. So when we test the mother and she happens to be living with HIV, then she has to take the blame because she's the index case. That's how it's been. But actually she herself has acquired the infection from her husband, and the husband has to be tested, and then the whole process goes on from there. So when we diagnose a woman with HIV, we have to remember, especially in India, that it does not land on a blank slate. It lands on a person who is already being shaped by gender norms, by lack of education, by economic independence, by playing the role of a caregiver, child bearer, child rearer, and she also has to, you know, she has her own dreams, aspirations and hopes, but that is secondary to all the other responsibilities that she has to bear. So we just want to focus a little bit on this, remembering that women are not just a statistic. They are also a daughter, a wife, a mother. And let's focus on the women for today's discussion and see what all she had to go through when she was diagnosed to have HIV. Because if we can change that state for the women, then we are making a difference. Otherwise, viral suppression, of course, is very powerful, but restoring the autonomy and dignity of a woman is transformative. So, before we go there, let's just ask a few questions. My first question would be to Dr. Mamatha. I don't know if you remember that in the past, there was a guideline for women who were pregnant and living with HIV, that we would put the woman on treatment, and once she delivered, the treatment would stop for the mother. This was a guideline that we followed for a few years before it was changed. But the treatment for the mother was given only during her pregnancy, and once she delivered the baby, the treatment was stopped. Now looking back at this, do you think this was fair?
Okay. With the current knowledge and understanding that we have, definitely we know that it was really not fair. Because in those days, when the focus was on maximizing the resources that were available to reduce the risk of transmission to the baby, and we did not really have a guideline from an international body like WHO saying that ART is required for all of them, irrespective of whether the woman is pregnant or non-pregnant. We believed in those days that that was the best which had to be done, because the ART eligibility as per the guidelines was based on the CD4 thresholds. So if the mother was found to have a good CD4, she was not a candidate to be put on ART, which would have been a lifelong process, exposing her to the risk of so many adverse effects and probably even the baby through breastfeeding. So the belief at that time definitely was to focus on delivering an uninfected baby and maximizing the resources. So of course it throws open a whole lot of social, ethical and medical issues that in today's day of understanding with better evidence, better scientific knowledge, we know definitely that was not fair. The woman and the child both matter. It's not just having an uninfected baby, but also ensuring that the mother is also very healthy and she will remain healthy and alive and be able to provide a good childhood and upbringing for her baby as well. So mother and baby both matter, definitely.
Also there was
has created an issue of resistance of the drugs. Those drugs now become useless for the armamentarium of antiretrovirals. So that is what we are seeing now with single dose nevirapine and archived resistance and all.
Ma'am, if I may add,
Yeah.
in 1994, when the mother of all trials, the ACT-076 protocol showed that mother-to-child transmission can definitely be reduced with a single dose zidovudin. That was what was followed. Then came nevirapine,
Single dose,
which was much simpler, lesser side effects, or as like Trupti actually elucidated it very well in her whole thing. Then the focus was on giving dual drugs, and maybe including or not including breastfeeding, depending on the the cultural and the social setting and all those factors. And then whether cesarean should be done or no. We at Wadia, Dr. Damania, have been very fortunate to work with Dr. Damania sir for more than 2 decades and seen this and implemented these changes in the guidelines as it evolved. So we were also doing just single drug. Then we said, okay, 2 drugs with a tail of, 2 drugs to carry on to cover the resistance possibilities with the nevirapine, which is supposed to be given during. And also we used to do cesarean sections electively when we did not have the national guidelines recommending cesarean, because our class of mothers could able to, get a viral load done. And if she did have a high viral load, we were doing elective cesareans as well. But then after the option B+ came in 2013 from WHO and it was implemented in our country, it is really simplified. There is no question of relying on all these things. It's a simple 3-drug regimen which has to be given to every mother irrespective of her gestational period, whether she is early in her gestation or late in her gestation, whether she is lactating, whether she is HIV 1 or 2, whether she has TB or hepatitis B or whatever else as a comorbidity. it did not matter. So TLD simplified everything. It focused on keeping the mother healthy and alive and virally suppressed as soon as possible like that, if the adherence was ensured. It also ensured that the baby will be almost sort of assured of not getting the infection if the mother is taking the ART. And the risk of mothers ending up with possible drug resistance with just a small period of exposure to ART, and probably a post-natal viral rebound and mother becoming more sick, which was all part of the option A and option B earlier. So B plus has really negated all that, and it's very clear that it's now both the mother and the baby who are very, very important.
Thank God for all the progress that has been made since then. But what I want to focus here on is the emotional state of a mother for whom her ART has been stopped. It's a guideline, and once the baby is delivered, the ART is stopped. What do you think that would have done to the mother emotionally? That she was less important than the baby? That it didn't matter if she was not there for the baby to be brought up? If she was not going to be... I had so many mothers coming and asking me, so now you're going to stop ART for me? Why? Now that I've delivered the baby, am I not important? What I'm trying to say here is, see the impact that this infection has had on women. It was a guideline that I'm glad, I realized why we had those guidelines. It was important at that time. But nobody really thought about what it would do to the woman. She felt unimportant. It was an unequal situation. She felt that her human rights were being impacted. So these are the issues that we had to face that time. Just extending on that, those days, the guideline was that we never had viral loads, we had only CD4 counts. So every woman was subjected to an elective cesarean section to deliver the baby. But at that time, what also happened is that many of those mothers who had undergone an elective cesarean section had their tubes tied off. There was information provided to the husband and wife, but it was not an informed choice. So what do you think? Well, anyway, we are opening the mother up to deliver the baby, so let's use this time to also tie the tubes up so that she doesn't have any more babies. So that was another thing which happened those days, and I would like to have your opinion on that.
Madam, I think that information is not correct because the tubal ligation was not forced upon any HIV positive woman. At least in the public setup, I can vouch for that. It was as voluntary as any other couple requesting tubal ligation. Contraception is an important aspect of any antenatal, intranatal and postnatal counseling, but tubal ligation, which is because she has been opened up, letters to her, tubal ligation did not happen. That is one part. At least in the scenario that I am witness to, and I can say that much was true. Now the second aspect of this was the whole information that was delivered regarding HIV. Now there were trials that were going on, and those people were getting drugs in a different way, and single dose nevirapine was one group. If we had to have, and there must have been some HIV support groups or something of that sort, then definitely that question of why not me would arise. But otherwise, all the information to the poorest of the poor was going through the healthcare providers. And when that information was going through healthcare providers, it was like, there is no other option but there is a CD4 count, and there is no other option but to treat with this CD4 count, you would be eligible for ART. That was the thing. So this pain of misfortune was there, but option is there, and I am being denied that option. Probably has been felt by less women than.
Having worked in this field for the last 30 years, maybe this was happening in the private sector, but I've personally had many women coming to me who had their tubes tied off.
Ma'am, if I may add, very fortunately, we personally didn't come across these sort of instances in our own practice here. But as late as 2018, there was a very good article published in the Journal of STD and AIDS, which said in more than 27 countries in 2018, that was not very long ago, in more than 27 countries, there were reports of women who were coerced into undergoing tubal ligations just because it was considered that it was unsafe for that HIV positive mother to have a baby, because we did not have sufficient resources and knowledge in preventing the baby from getting HIV infected. So many a times it was like a informed coercion into agreeing to get a tubal ligation done as well. So this article had come in 2018. So it was, and elective cesarean section was used as an opportunity where the tubal ligation was done along with it.
Yeah, and also the fact that she was not on ART at that time, her health would deteriorate. Would she be able to manage a second pregnancy if it were to happen? All these issues were considered when they did that. But that was an event which was happening. I'm happy to say that according to the NACO reports of 2024, 16,000 women were identified to be living with HIV till November 2024, from January to November 2024. Out of the 16,000, 9,000 were women newly diagnosed who became pregnant for the first time, and we had 7,000 women who had a second pregnancy. So that's a good thing that's happened. Now women are allowed to have more children, and we have women who've had 3 children, 4 children also happening nowadays. But this was something that happened in the past, and again it was something which impinged her rights. So I just wanted to bring it into the forefront to show what all women have had to go through because they were living with HIV.
Was it without informing them?
No, they were informing them, but it was not like, what do you think?
It was like onus of passing to the baby is on her, and she better not give birth to a baby.
She was not given the correct information
It
about
was misleading by sort of giving, and
you can't do a
in that
tubectomy
particular
without the
article, if
person's
you go through,
information.
there were instances where they were sort of told that in order to have a cesarean section done and in order to manage the baby as well as your own health, a tubal ligation is also an important component. So they were coerced into saying yes for it many a times. Or under anesthesia or another relative, they were just consent was sort of taken on paper and tubal ligation was done, which was quite a big concern.
So I'd like to move on to the next question to Dr. Srikala Acharya. Did you receive my questions? Yes.
Yeah.
Okay. I'm sorry, I'll just ask Dr. Padmaja this question. Why does HIV-related stigma affect women differently from men?
It's because we talk to women differently. Somehow we still talk to women differently. Very few doctors talk to women about sexuality, talk to women about sex. Very few doctors give full information about, because generally we consider that women do not understand as much as the men do. So this is in the health sector, but otherwise when she goes back with a baby or when she is at home with the child, the guilt that the woman has, extreme guilt. She doesn't know where she has got the virus from. If we are to go by morning's discussion, if the partner is not tested, she doesn't know that she has got virus from the partner, and that the responsibility lies with somebody else rather than her. So she suffers with that guilt. If the virus has been tested and the husband has been tested and he is positive, then the fear that the breadwinner of the family is likely to have all those later health complications and the risks are similar. And the way a woman is treated as second-class citizen in her marital family, and she is likely to be thrown out if the husband succumbs. If she has a female child, the chance that the child is also thrown out. If she has a male child, maybe child will be kept and the wife will go out. her opportunity for earning. Now the HIV Act which Dr. Trupti mentioned, that is something that is there, but how many people know that there is an HIV Act and she can demand a shelter and she can demand opportunity for a job, etc., etc. So the fear and the guilt, these are the two things that are very predominant on her. Guilt that she might pass on the virus to the child, guilt that because of her illness the child is going to have the virus and subsequent issues associated with that. These are the things that the woman lives.
Actually, the
I
stigma
also we need to
reduced.
say-
The stigma reduced when the terminology changed from mother to child transmission
To parent to child transmission, yes.
So this was a huge thing which happened at the government level, and that becomes like a shared responsibility and diminishing the stigma.
Yeah. See, when we were talking about mother to child transmission, we were talking about a biomedical transmission, and that's why it was labeled as mother to child. But then we realized that in a country like India, if you exclude the father from it, the entire blame goes on the mother, and that's why we did the parent to child transmission. But I'm not just talking about the context of pregnancy. I'm talking about overall. Why is it that stigma for a woman is different from that for a man? One of the things is that we are a patriarchal society. And men have the moral authority here. Men are the head of the families. Men have more powers. Men have primary power. They have dominating roles to play in the family. They have control over property. Whereas a woman is looked at as a person who is primarily responsible for child care, domestic work, limiting opportunities for them. I'm talking mainly about women who belong to the status where they are infected with HIV, not generally.
Otherwise, also women have the same
problems.
Same problems.
That's true to some extent, yeah. So we are looking at a double standard here, actually. A woman's identity is closely linked to her sexual purity, her marriage, motherhood. If a man has multiple sexual contacts, it's okay. He needs the experience. It's okay. It's looked on as if he's very virile and strong. It's fine. It's his mistakes are forgiven. But a woman's is not. And poor thing, she hasn't even made a mistake, but yet she gets labeled. And so that is something that we have to remember, that we are actually a patriarchal society, and that's why we live in an atmosphere where a woman has no autonomy, no choices, nothing, and that's something that we need to change. It is changing, but it hasn't changed completely, but that is something that we need to look at. Dr. Srikala, what is the silent psychological burden that a woman living with HIV bears?
Actually, when it comes to women living with HIV, and when we are, and it is a gendered role, especially in our society, the cultural roles that she plays and expected to play. So what happens is that, we have come across pregnant women who are diagnosed positive as an index case, husband is positive, but they are not able to share or disclose their status to other in-laws because no one wants to know that she is positive. They both keep it to themselves, and this is the situation for newly diagnosed pregnant women. The other women aging with HIV, and they are widows, their husbands have died of AIDS, and you have another extent wherein they have not, if they are staying in husband's house, they have not disclosed their status to the children who are uninfected, who are grown up. They have not disclosed their status to families, in-laws families, because they feel, if I am thrown out at this age, where do I go? There is no one for me to fall back upon for support. And there are multiple comorbidities associated with aging. So, and they are not earning members. They can't work now. Either if they are working because they have to look after their children in the middle age, it's most of the times as domestic servant or some low paying jobs, and they have to carry the dual burden of looking after their illness, if child is positive, the child's illness, as well as earning if she is already widowed. We have had widows at the age of just 20, 21, 22 within a year of marriage, even in Mumbai. Because even after 30 years of the program, we know that at the time of diagnosis, 30% are already in advanced stage of HIV disease, and men who have lower CD4 count at the time of diagnosis, and the chances of deaths are higher because they have come too late with OIs, multiple OIs to us in the program. When it comes to a person who is, if it is taking treatment from private sector, and we have experienced this during COVID, when there were a lot of insecurities because of the jobs, financial losses, etc. Many people stopped treatment. Many had to migrate. So this, when we say psychological burden, it is, even if she is aware, she doesn't know who to seek information, who to seek support, both financial, otherwise, and there is nothing there. We don't have any that kind of structures to fall back upon. Though we have ART centers and counselors who are trained, they look into only the treatment retention, viral load suppression, etc., etc. They do not necessarily look into the overarching needs, that unmet needs that this woman or the couple would need in terms of planning for the pregnancy, planning for baby if they are desirous of, what, where, how do they seek this guidance from. So these things are unfortunately missing from the entire care continuum that needs to be given to not just the woman but the family as such. The family-centric approach is
very important.
Missing.
Yeah. When I started working in this field 30 years ago, the first thing that happened was we were seeing a lot of young women who had become widows. What happened was women were getting married and they didn't know whether their husbands had HIV or not. They were not being, their husbands were not tested. And about 10 years into the marriage, the husband would become sick because by then he had reached the AIDS phase. He would get admitted, multiple opportunistic infections, no treatment for HIV per se, he would die. And then you had this young woman left with 2 or 3 children, and she was a widow, no financial stability. Her in-laws would say that you're the one who brought bad luck to the family. It's because of you that the husband died at such a young age. They would deny her any family property. There was her biological family would not accept her because they said, we've already spent all the money for your marriage. Now we can't take care of you and the kids. And this woman had nowhere to go. And in Bangalore city, over that period of a few years, we had 100 such women who came into Asha Foundation. And even today, they are with us. And we've helped them tide through that phase. We've put them on free ART. We've educated their children. And the children are all now grown up, completed their degree, have got jobs, have got married. Many of them have children who fortunately are HIV negative. So we have the 3rd generation of families that are HIV negative. We had a focus group discussion with these women because we had developed a rapport with them, and we divided them into 2 groups. One group was where the children were HIV negative, and one group where the children were living with HIV. And one of the things that we asked them was, are you angry with your husband? I mean, they were widows. But they all said yes. There was suppressed anger in them about what had happened to them because of their husband. At the same time, there was also a lot of affection for the husband who had gone. But they said, we feel so angry, especially not so much for ourselves, we can bear it, but the fact that our children get infected. And for that, we can't do anything. So there's a lot of, what we saw was a lot of depression, a lot of internalized stigma, suppressed anger, forced to keep silent because they felt betrayed, but they were not able to talk about it because it's very important about how the society looks at them. And all of this affected them in a great way. And they don't tell their children that they are living with HIV. They said, let this infection die with us. But in the children who were HIV positive, living with HIV, the mothers said, we have to tell our children because they need to know where they got the infection from. So theirs was a little different between the 2, but both groups had a lot of suppressed anger, and both groups felt very betrayed. So they have to carry this psychological burden for the rest of their lives. And by giving them support from organizations and women like us who work with women living with HIV, we can help them to overcome what they feel. My next question is to Dr. Karanjakar. Do you think that women living with HIV are now, over the years, meaningfully represented in policy-making decisions? How can women move from being beneficiaries to leaders? And what does nothing about us without us mean?
Nothing about us without us. It's a very loud slogan. It means that policies, programs should be relevant or made with the participation or representation from the people whose lives are affected by that program. They should be a part of policy making or decision making policy making body. So here, as we discuss, women living with HIV in Indian context is to involve them in policy making is very important. As we discussed, in India, there is gender violence is significant. Gender inequalities are there. Along with that, the economical dependence of women is significant, and stigma related with HIV is present. In this scenario, involvement of women living with HIV in policy making decision is very important for their adherence to the treatment and providing the services which are relevant with them. So, in current situation, government or NACO program or NACP involving the women's representation at various forums like TRG group. Along with that, some network or pressure groups are there and they are the part of that, and also the advisory bodies, they are part of the advisory bodies, and civil society platforms which are used. Various consultations are organized and women's representation is there in these consultations which help in formulation of the newer policies. So significantly, this participation is there, but for the meaningful participation, we have to move ahead. From the participation to the partnership role, from the consultation to the leadership role, we have to significantly move ahead. And then we can definitely say that nothing about us without us we will achieve.
Thank you. My next question is to Dr. Srikala. How do we move from prevention of mother to child transmission to respectful reproductive choice?
As it has been discussed earlier too, we have been looking at, when we say PMTCT or PPTCT, we are looking at the woman who is coming to us or the couple who is coming to us, and we are ensuring, and the services are to ensure that baby born is uninfected. But we also need to look at as to what are their choices, rights, to ensure that they can implement those reproductive rights, and understanding what these rights are and empowering our healthcare providers to ensure that these rights are met with right information, counseling, as well as the places where they can be accessing these services. Because many a times the stigma associated with that label would mean that you are just negating that choice that the couple has to have an wanted pregnancy happen at the right time in a right way. We just say that, okay, ye ho gaya, no next time. Why do you want to have another child? Who will look after? But then they have that right to decide. And I suppose this is important, and we need to build it into the training of our healthcare providers, right from care coordinator to policy makers, that we need to go beyond the biomedical models of just preventing or elimination of vertical transmission. We need to ensure that how do we actually achieve these rights in a right-based framework for women and couples living with HIV.
And abortion. Yeah. So,
which is so many times actually, in certain setups it may be denied. That's so
unfair. Yeah. The main thing is informed choices, shared decision making, and integration into reproductive health services. Those three would be the key points, where you also include them in, screening for NCDs, screening for CA cervix, supporting them mentally, all of these things that we need to do. I just have two more questions before we wrap up this session. My question is to Dr. Padmaja. What about older women living with HIV? Are they invisible in our programs?
in a sense, as long as they are in ART program, their medical needs are being taken care of. Now, besides ART related medical needs, the program is so overburdened and there are so many beneficiaries who are there. So it cannot really manage comprehensive healthcare for them, and contribution of other streams has to be there. Now it will be, I think, Mumbai MCGM rather, Bruhan Mumbai Corporation, a month ago started menopause clinics in all tiers of hospital. So it is there, and whatever was discussed, the drugs are also going to be purchased now. We are listing the drugs which are required for care of menopausal women, etc., etc. So probably these women also will come to these clinics, or some integrated service would be given to these women. But having said that, we do not consider, as sometimes ago somebody said, two groups do not have sex. One is our children, one is our parents, right? So the sexually good. And we say reproductive needs. There are sexual needs also, and understanding of what they need. If they have any other reproductive tract related problems, then addressing those things, because denial of surgeries, denial of otherwise care is a reality for these women. So their NCDs like hypertension and diabetes would be looked after, but otherwise they are still marginalized. They are still, I won't say invisible, but they are treated differently, definitely.
The other thing was that, a lot of research has gone on in PMTCT, but we don't have much research going on in older women. In fact, they've actually been ignored initially, and much of the research was done in men. But that has improved over the years, and now a significant percentage of all research involves women intentionally, so that you know what's happening to them once they are past the reproductive age group. My last question is to Dr. Karanjakar. What economic empowerment models have worked for women living with HIV?
Though there are few models like skill development or social enterprise model, but one model which is tested and well implemented in Mumbai is self-help group model. We started self-help group at JJART Center with initial rotatory fund support from the planning department of BMC, and we help them to have a skill in catering and catering business, and help them to establish. Now they are well established, self-sufficient, and act as an inspiration for others. Now we have 5 more self-help groups in other ART centers, and 5 are in, we are in a process to form. So this is a easy and well-tested model, a self-help group. We can form the self-help group with the women living with HIV, encourage them, and have the self-reliant, and that way we can help them to have an empowered life.
we've also looked at, feeding them into the government schemes which are already there, like widow pension and pension schemes for women. So we can fit them into those things, educational schemes, supporting of children for education. All of that we have done, we can do. So there are lots of empowerment models that we have. There is something called conditional cash transfers, where if you say that we're giving you this sum of money so that it's not yet there in India, but we're giving you this sum of money so that you can educate your children and you can buy your rations for the month. It happens in a lot of African countries. So those are some of the things that we can look at. Providing them legal services so that if they're fighting for their husband's property, they have a chance. And also job placements for them. So there are so many ways in which we can empower these women. And this entire panel discussion was just on the woman, but the woman living with HIV, but we focused only on the woman and not on the virus. So in future, when you are meeting women living with HIV, please keep this in mind, that she's not just the virus, she's also the woman. Thank you.
In our patients, for any woman or for a girl. So where to, whom to approach and get the help from? Is there some central body where they can address the issue? For example, say we have some positive men and they want to get married, so they go to their villages and get their wives without telling them. We tell them that this is not done. You told us it seems that U is equal to U. That's what they take our sentence from, and they say because it is U is equal to U, what is the problem? I'll keep her happy and not ever infect, as you are saying. What is the need of telling that girl? So this is definitely injustice done to that girl, right? So where to address these kinds of issues?
Legally, they have to inform whether U is equal to U or there is there or not. Legally, they have to inform. The HIV/AIDS bill states that a man cannot marry a woman without informing the woman about her status. And then we get them in for counseling. We explain everything. The woman has to make an informed choice whether she wants to marry or not. We have a long way to go there also, but it is happening. It should begin. It's difficult. Also, we have marriage bureaus. Many of the networks, positive networks, have marriage bureaus, and we get lots of requests for women or men wanting to get married. And so they find them, and we help them to get, everything should suit. Both of them should be, we look at CD4 counts also to see, we don't look at horoscope matching so much as we look at whether they match medically.
They don't agree for that.
Yeah.
They don't want that kind of, we are just going to go ahead because already a girl has been decided.
Yeah, but that's not right.
That's
Yeah.
not right.
We are running behind time.
There's only one area of concern where, see, antenatal mother fine, she comes to the hospital, she is detected. But if a male is positive and he doesn't bring his spouse for testing, because many a times they have varied reasons, gaon mein hai, idhar hai, udhar hai, doesn't bring the spouse for testing. So what are the efforts which are taken by all of you for getting that spouse definitely tested?
We just work on it. Sometimes it may take as long as 2 years, but every single visit we work on it. It's not easy. You know how difficult it is in a patriarchal society.
The question about where she can seek legal redress is the question.
Yeah.
So this is actually a type of violence against women.
Yeah.
Yes? Yeah. But the bodies that are working on domestic violence prevention, they do not understand that this also is a type of violence.
I suggest that we discuss this during the tea break or lunch break, because we're really running behind time and we have to finish this. Yeah, so thank you also.
Please, can we have the panelists to receive their little potted plant? We'll just take a group pic. One more.
Just take a photograph. Thank you.
With that, we move on to our next talk. on STIs, and for that we have Dr. Kirti Jangid. Who are the coaches? And our co-chairs are Dr. Reena Vani, Dr. Shastri. I'm so sorry, madam.
No, that's okay.
Dr. Sujata hasn't arrived yet, but I think we'll continue. Dr. Vani was just around, right?
Yeah,
She'll come back. Dr. Vani and Dr. Shastri will also share with us about the study that they are doing.
Respected clinician, she plays a pivotal role in strengthening the recognition and management of sexually transmitted infections, with a focus on infections that are often overlooked in routine practice. Today, she speaks on STIs that are often missed.
Very good afternoon to all of you. At the outset, I would like to thank the AIDS Society of India and MOGS for having me here to have a conversation on this topic with all the esteemed faculty. Thank you so much. So I'll be speaking on female sexually transmitted infections which may often be missed. So the STI annual burden in India, as estimated by NACO, is approximately 6%, and we are definitely seeing a resurgence of syphilis. With increasing seropositivity, the rates being as high as 0.7%, about more than 1 lakh pregnant women have been estimated to have syphilis annually, and more than 2,500 infants treated for congenital syphilis. So what are the causes of missed STIs in women? Most of the STIs like chlamydial, gonococcal infections are asymptomatic in about 70% population. Certain infections like HPV may be silent or may be subclinical. Certain infections like mollusci are missed or may be subclinical. Early syphilitic ulcers or LGV ulcers may be transient, may resolve spontaneously and may remain asymptomatic. They may be on atypical anatomical sites, they may be on the vagina, cervix, and hence missed. Atypical sites like oral cavity, perianal region, rectum are often overlooked sites or not looked for as a site of STI. Then there may be atypical clinical presentations with increasing seroprevalence for HIV and mixed STIs being more common presentations than normal. The clinical presentations are often atypical. There may be associated comorbidities like diabetes and HIV responsible for masking presentation or having an atypical presentation. Most often than not, there is always a lack of partner evaluation. Spouses or sexual partners are not brought for examination and are often not tested, which is responsible for missed contact tracing and thereafter reinfection. And there is always over-the-counter antibiotic usage like amoxicillin or azithromycin, which are usually not given in appropriate dosages, and this is responsible for suppression of symptoms and continuation of a silent disease progression. What are the consequences of these missed STIs? We all know tubal infertility, chronic pelvic pain and pelvic inflammatory diseases, ectopic pregnancy, adverse obstetric outcomes like preterm labor and vertical transmission of HIV and syphilis. All ulcerative and non-ulcerative STIs definitely increase the risk of HIV transmission by 2 to 5-fold. Pre-existence of HIV disease itself may modify STI presentation by having a more atypical and florid presentation, severe presentation and treatment-resistant forms. So STI screening is definitely an essential component of HIV prevention programs. So as dermatologists, we see more of genital ulcers, atypical herpes or syphilitic skin rashes, secondary syphilis manifestation, genital warts molluscum, and gynecologists primarily see consequences of STIs like infertility, pelvic inflammatory disease, cervicitis, vaginitis, endocervical discharge. So cross-speciality collaboration and referral systems are definitely essential for comprehensive STI management. What are the different causative agents for common STIs? RTIs, all viral, bacterial like HIV, genital herpes, warts, hepatitis B, C, syphilis, treponema pallidum, gonorrhea, chlamydia. They may be ulcerative or non-ulcerative. We will deal with them very briefly. What are the symptoms of signs of STI in women? So women, the symptoms and signs will differ depending on the type of penetrative sexual contact. If there has been a peno-vaginal contact, it will be unusual abnormal vaginal discharge, vaginitis or ulcers around the vagina, maybe on the cervix or vagina, then dyspareunia, lower abdominal pain, blisters, ulcers and genital warts. If there has been a peno-oral contact, penetrative without protection, then there can be blisters or ulcers on the oral cavity, lips, tongue. There can be pharyngitis, sore throat, which can be manifestations of gonorrhea and chlamydia, difficulty in speaking. If there has been an unprotected peno-anal intercourse, then there can be anal discharge, tenesmus, bloody discharge in stools, pain around the anal orifice or fissures around the anal orifice. Of course, ulcerative STIs can give rise to ulcers around the anal orifice. So coming to clinical presentations, herpes genitalis is very commonly seen, caused by herpes simplex virus, more commonly 2, less commonly by HSV1. It presents commonly as clustered vesicles on erythematous base on the genitalia. It can also present as multiple erosions over vulva. Atypical presentations include fissures, dysuria, erythema without vesicles and treated with acyclovir or valacyclovir. Suppressive therapy may be considered for frequent recurrences. This is herpes genitalis in a immunocompromised host. So as you see, normally the cluster vesicles are erosions are small. In immunocompromised hosts, they are large, deep, they go a little deep, they are confluent, they have polycyclic margins, and they require long duration of acyclovir therapy. So normally we give for 5 to 7 days. Here may be extended up to the lesions resolve completely. Syphilis is a bacterial. Syphilis is caused by bacterial spirochete treponema pallidum. We all know that it has stages: primary, secondary, latent, and tertiary stage. Where in primary stage you may see an ulcer, which is seen on the exposed area like the genitalia and peno-vaginal contact. Secondary syphilis is a generalized distribution. So there's a common generalized rash. I'll show you the pictures. Latent syphilis remains silent where there's only seropositivity, and tertiary syphilis may have neurosyphilis, cardiovascular or benign tertiary syphilis. So this is a primary syphilis where you see deep necrotic genital ulcers. Normally these ulcers are painless and they are associated with painless bilateral inguinal lymphadenopathy. In women they may be unnoticed because they can come on the cervix, vaginal wall or posterior fourchette, hence easily missed. This may heal spontaneously in 2 to 6 weeks again, hence the syphilis may go unnoticed. In secondary syphilis, you get either a generalized rash or you can have cutaneous manifestations like what is seen in the picture as erythematous papules and plaques over palms and soles. This is a manifestation of secondary syphilis. You can have patches of hair loss on the scalp called as alopecia or moth-eaten alopecia. Then systemic features like fever, lymphadenopathy. See, this is secondary syphilis where it classically presents as erythematous papules and plaques over palms and soles. Then again, secondary syphilis in the second picture, it shows something called condyloma lata where there are greyish, white, moist patches. These are highly infectious, seen on the perianal region. Then again, mucosal, oral mucosal involvement is a case of secondary syphilis where it presents as reddish patch, erythema, we call it as mucus patches on the hard palate. It can come on the lips as well. Again, erythematous papules and plaques over palms and soles in secondary syphilis. How do we treat syphilis? In early syphilis, less than 1 year, we give a single dose of injection benzathine penicillin, 2.4 million units IM. Late latent, that is more than 1 year duration, we give 3 doses of injection benzathine penicillin. And neuro, oto and ocular syphilis managed with aqueous crystalline penicillin for 10 to 14 days. LGV or lymphogranuloma venereum is caused by chlamydia trachomatis L1, L2, L3. Again, this has stages. Usually the primary stage, the ulcer is transient, it heals spontaneously in 7 days and hence again it goes unnoticed. And we see the patient in secondary stages where you get something like the first picture. There's an inguinal bubo or a lymph node swelling which appears as a swelling in the inguinal region. This is the femoral lymph node which is enlarged. Then we also see patients in the tertiary stage where it has the ulcer has resolved spontaneously months before the infection. Patient is infectious and you see this. This is because of the lymphatic damage. So it has caused osteomy, that is enlargement of the genitalia because of the lymphatic obstruction. So this is histamine in a case of lymphogranuloma venenum. It is managed with doxycycline 100 mg twice for 21 days or azithromycin weekly. Donovenosis is another ulcerative STI caused by Klebsiella granulomatis. It has a long incubation period and it presents as beefy red genital ulcers. They normally bleed to touch. They are large granulomatous ulcers. They can also present as subcutaneous granulomatous lesions which may appear like lymph node. Okay. Again, that's why these may go unnoticed and they are managed with doxycycline or azithromycin long course until all lesions heal. Chancroid is less commonly seen, but it may be seen along with other STIs. It presents as necrotic, little deep ulcers, normally very painful, and they are kissing ulcers because they spread with contact. So that's why they come on opposing surfaces. This is a classic case of bilateral kissing ulcers of chancroid and treated with azithromycin 1 gram stat or ceftriaxone injection. So persistent or recurrent cervicitis is what gynecologists normally see. And a lot of multiple organisms cause recurrent cervicitis like chlamydia, gonorrhea, mycoplasma, trichomoniasis. This is like a sum of all the organisms causing, as you see in the first column, most of the cases are asymptomatic. So about 50 to 70% are asymptomatic. Normally they come as co-infection. So if there is gonococcal infection, one has to treat for chlamydia as well because they come together. Most of them have coexistence. And they present as cervicitis or mucopurulent discharge. It is difficult to diagnose the infection based on the discharge, although classical textbooks mention frothy discharge, greenish discharge, whitish discharge, but more often they are mixed infections, so one cannot usually diagnose based on the color of discharge. Diagnosis establishment is per se with NAT, nucleic acid amplification test, and treatment is depending on the type of organism that you suspect. Gonorrhea and chlamydia when present are often treated together. So because of fluoroquinolone resistance in gonococcal infection, we often give a third generation cephalosporin for gonorrhea and we combine it with azithromycin either 1 gram or doxycycline 100 mg BD for 7 days to cover chlamydial infection as well. If the infection persists, then we suspect Mycoplasma genitalium infection and we combine doxycycline followed by moxifloxacin for 7 days because again Mycoplasma genitalium is now showing resistance to azithromycin based treatment modalities, and most of these cervicitis causing organisms cause complications like PID, infertility, ectopic pregnancy. Hence it is important to complete the treatment in such patients and follow up maybe for test of cure, that is NAT, after 1 month of treating. Genital warts, often they go unnoticed as skin tags. So they present as, if there are 1 or 2 of these lesions, they are normally missed because they are asymptomatic. They do not cause any pain, discharge or itching, and this is how they present: greyish white, okay, but cauliflower like lesions. They may be very small that they go unnoticed, but they can definitely transmit the disease to the sexual partners. Usually low risk strains like HPV 6 and 11 are responsible for these warts. And treatment is with cryotherapy, trichloroacetic acid or bichloroacetic acid, cautery, 20% podophyllin or emicomod cream. These are vulval warts. See, this is a perianal skin tag, which is often, perianal warts is what you see in the other picture. So that's why there is a confusion. They often go unnoticed as perianal skin tags and they may be missed. Molluscum contagiosum, it's again, genital molluscum contagiosum is a sexually transmitted infection and it is caused by pox virus. It presents as whitish papules on the genitalia. Okay, they have a small umbilication, so they look pearly white and have an umbilication, and they are often missed as folliculitis, and such patients receive long duration of oral antibiotic and multiple courses of oral antibiotic, but this is also an STI and we often test the patient for other STIs like VDRL, HIV and everything. Hepatitis B, C. So in genital location, strongly suggests sexual transmission. Treatment is by extirpation. We remove the lesion with a needle and touch the base with trichloroacetic acid. Pediculosis pubis, so it is often not known that pediculosis pubis or pediculosis infection of the genitalia may be a sexually acquired infection. So again, this is an STI. It is transmitted between partners. It may be associated with other STIs along with this. And when one closely, it is usually missed as eczema or dermatitis. Patient complains of intense itching throughout the day. When one closely looks through the lens, you can actually see the pubic lice either on the skin surface or on the hair shaft, and you see nits on the hair shaft. Okay, lice can also live in the seams of clothing, and you treat it with 1% permethrin application for 10 minutes and repeat after 7 days, and also treat the partner, look for other STIs. Scabies infestation, again genital scabies is a sexually transmitted infection, so there might be other STIs along with scabies. Hallmark symptom is nocturnal pruritus. Look for other site involvement like wrist, breast, periareolar sites and abdomen. And it presents as papules, nodules or excoriated lesions. Again, this is missed as eczema or dermatitis. It is managed with 5% permethrin. Overnight application may be repeated after 10 days to treat all sexual partners to evaluate for other STIs. So this is excoriated papules over wrist and scrotum. This is a transgender presenting with genital scabies. He also had primary syphilis. Then when there is history of STI, one should always ask for the type of penetrative intercourse. So if it was vaginal, oral or anal, and always evaluate and take history of rectal symptoms or anal symptoms like tenesmus, discharge, pain while defecating, blood in stools, because these are manifestations of STI which can be because of peno-anal contact. So depending on the type of organism, gonorrhea and chlamydia may present with discharge or blood in stools, whereas syphilitic herpes ulcers may have actually ulcerations around the anal orifice. So always examine the perianal skin. Consider rectal or anal gnat in high risk exposure to rule out gonococcal or chlamydial infections. This is a case of perianal warts. The first picture is that of perianal herpes, second picture is perianal syphilitic ulcer, then another anal mucosal and perianal warts. Perianal warts in PL-HIV, so florid lesions, multiple lesions are seen and they are going into the anal canal. This is perianal herpes in a PL-HIV. I told you the herpetic infections are usually large, polycyclic and difficult to manage. Again, oral STI when there is history of oral sex or penetrative and non-protected oral sex. So it's important to elicit the history. So again, syphilis will present with chancre or mucus patches, that is reddish patches on the oral mucosa. Herpes can have painful vesicles. Gonorrhea and chlamydia will have symptoms like sore throat, redness and difficulty in swallowing or voice changes. So always examine the oral mucosa, consider throat gnat in high risk exposure, and pharyngeal gonorrhea is a key site for AMR surveillance. So this is oral STI. You can see perioral wart in a female, and this is a case of primary syphilis with a chancre at the oral commissure. So that's a primary chancre which is seen on the genitalia. Here in this case, because of oral penetrative intercourse, it was seen at the oral commissure. So I have shared certain cases with you. This is a case of a 22-year-old unmarried female. She presented with pinkish papules at the angles of mouth of 1 month duration. She was managed as angular chylitis outside, and on examination she came in with her partner. There were erythematous plaques on the palms and soles in the female. Partner showed mucus patch over the hard palate, and here in the female you can see that there are papules. These are called as split papules at the oral commissure. So on evaluation, the VDRL was 1:16 in female and 1:8 in the partner. Both tested TPHA positive. They were diagnosed with secondary syphilis and managed with single dose of injection benzathine penicillin 2.4 million units IM after sensitivity testing. So the learning point here is palm and sole lesion with mucus patch with history of sexual exposure. Always rule out syphilis. This is a second case. She's a 24-year-old sexually active woman. Who presented with a generalized erythematous succulent scaly plaques all over the body. Head to toe she had similar lesions, and there was a history of whitish vaginal discharge since 1 month. She gave history of multiple sexual exposures in the past 2 to 3 months. Her VDRL tested 1:64. Her TPHA was positive and she was diagnosed with secondary syphilis. Again, she was managed with single dose of injection benzathine penicillin 2.4 million units deep IM. And she was, this was a variant of secondary syphilis. This is called as granulomatous secondary syphilis. So she had a high titer with an atypical morphology. This is a 18-year-old unmarried female with history of 5 months of amenorrhea, with painful genital ulcers of 1 week duration. She had multiple unprotected sexual exposures and gives history of applying herbal products locally. On examination, there was significant labral edema with well-defined ulcers on bilateral labia with purulent discharge and tender inguinal lymphadenopathy. No other skin lesions were seen. She tested VDRL positive with a titer of 1:16. Her TPHA was also positive. All other investigations were negative. Her USG showed a 23 weeks live intrauterine pregnancy. She was diagnosed as a case of primary syphilis in pregnancy and managed with injection benzathine penicillin 2.4 million units, DPIM weekly 3 doses. She delivered a healthy baby at term, and the baby's titer were lower than mother's titer at birth. However, the baby was given a prophylactic single dose of injection benzathine penicillin G. This is the next case is that of an 18-year-old married female with 9 months gestation who presented in labor. She gives no history of prior ANC visits. In labor, her VDRL titer was 1:8 and was later confirmed to be TPHA positive. She delivered the baby with a unilateral cleft lip. The baby's VDRL titer was 1:8 at birth, and there were no skeletal deformities. Again, the father was tested, and the father was VDRL positive with 1:16 and TPHA positive status. So it was diagnosed as a case of suspected case of congenital syphilis in the neonate with latent syphilis in both parents. And this baby was managed with injection IV aqueous crystalline penicillin G for 10 days. And both parents were given injection benzathine penicillin G 3 weekly doses. So here the learning point is missed ANC screening is definitely preventable. So coming to the current challenges in India, we rely a lot on syndromic management, which remains the backbone of STI management at primary care. However, we need to combine syndromic management at primary level and to combine it with NAD-based etiological diagnosis in tertiary and urban care practice. Universal antenatal screening does include HIV, syphilis, hepatitis B in the first trimester. Important to ensure that this happens. There is limited access to NAD-based etiological testing beyond tertiary centers, and there is also rising antimicrobial resistance in STI pathogens. So gonococci or gonorrhea has shown widespread resistance to fluoroquinolones in India. Hence, ceftriaxone-based or third-generation cephalosporin-based therapy is recommended. Mycoplasma genitalium infection is showing increased macrolide resistance, and moxifloxacin often is required in combination with doxycycline. Concluding, many female STIs are asymptomatic, about 50 to 70%. So, active screening is definitely crucial. Integrate STI screening into gynecology visits, infertility workups, and antenatal care. Persistent or recurrent vaginitis definitely warrants full STI evaluation, including NAD testing. Examine oral perianal sites in all sexually active patients. Partner notification and treatment are essential to prevent reinfection. Promote patient education and rational antibiotic use. And early diagnosis and treatment of STIs prevents ectopic pregnancy, adverse pregnancy outcomes, infertility. These are my references. I thank you all for your patient listening.
Thank you, Kirti, for your lucid talk. So, can we have the lights and lines, please? So, for the benefit of all of you, I don't know whether you're aware, the Department of Microbiology in Nair Hospital is the regional center for diagnosis of reproductive tract infections and sexually transmitted infections. We do get a lot of samples from other public hospitals if there is any suspicion and problem in diagnosis. Yes, there is syndromic management, but we are also doing etiological diagnosis right from 2018. The center has been functioning. Now, as part of the national program, there is strengthening of these centers. So we have been doing the combo kit for syphilis, hepatitis, and HIV. Diagnosis, and as part of the screening of women for reproductive tract infections and STIs also, all suspected women from both the HIV clinic, that is from the ICTC by the counselor, or from the Gynaec OPD, are sent to the lab for etiological diagnosis. When I say etiological diagnosis, we are doing NAT testing also. So this is for your information. And one very important thing which I would like to share here is the missed STI. The missed STI in the HIV, the women screened for HIV. Now we have an ongoing study. We have two PIs with us, Dr. Reena Wali from Cooper Hospital and Dr. Sachi Agarwal from Nair Hospital. The two PIs of this study are here, and we are looking for HPV infection amongst both HIV positive and HIV negative women. And to our own, I would say anticipation, I wouldn't say shock, we are having 30% of HIV negative women with HPV infection. The CEPHID speaker is here, the CEPHID representatives are here. We are doing it by gene expert, the CB-NAT. And we have also done the genotyping using the C gene. And I must tell you that the results are absolutely matching, but of course the C gene also detects more than 16 and 18 genotypes. So this is the information we would like to share with you. And we have been struggling, trying to make this policy with NACO. But here I would like to, since the company people are here, the cost is the limitation. So if somewhere you could work around the cost, we are missing a lot of HPV infection. So in HIV positive women, it is 50%, and in HIV negative women, it's 30%. So all HIV negative women should also be screened for all the STIs. And as part of strengthening of STI services, NACO has also introduced CT-NG molecular testing using CB-NAT at the regional STI RTI labs. So if you have any suspected cases, at least in Mumbai, you can send them to Nair Hospital for molecular diagnosis and further NAT testing. Over to you, Rina.
Congratulations, Dr. Kirti. Today it's International Women's Day, and the colors are purple, green and white, which have different symbolizations. But one thing I'd like to say, the interface between gynecologist and skin department is very much important. We had a young girl, 9 years old, coming with skin lesion suggestive of herpes. Now, this is a hidden infection, and then when it was tracked, it was found that she was VDRL positive. So violence against women and girls is also a very important aspect which can be picked up when you look for hidden infections. And these are certain cases. I appreciate your highlighting the fact that congenital syphilis is raising its head again. Even in tertiary care hospitals, sometimes we are so focused on the HIV program that cases of congenital syphilis are being missed. So in fact, our program is now, the name has been changed to Elimination of Vertical Transmission of HIV and Syphilis. And we have our representatives from MDAX here who are doing a great job in sensitizing everybody. And there's a saying that the eye does not see what the mind does not know. So a lot of times, definitely syndromic management is the mainstay. We are using it in most patients, but what is important is partner treatment. Ask the hard questions in a nice way. Sometimes we feel awkward to ask about how many partners, is there oral sex or anal sex. So we have to be polite but firm and ask these questions, then only we will get some answers. So I congratulate you on a very lucid presentation. And does any of the audience want to ask a question before we move on?
I have just one additional point to make. In addition to syphilis, we are seeing a surge in cases of gonorrhea too. So when I say surge of cases, these are all smear positive. Some of them grow in culture because as part of the regional center, we have to also report the sensitivity to the WHO. So they do sometimes grow, but of course smear positivity is also on the rise.
I just want to add one thing.
Another very important thing is cervical cancer screening. Dr. Jayanti talked about HPV. I'm sure all of you are aware that liquid-based cytology is very much available in our country. In the public hospitals, we do not offer it free of cost. But in a person where there is some kind of discrepancy and all, and we must be aware that our own beloved Prime Minister Modi ji has launched a rollout of the HPV vaccine. In fact, in public hospitals from tomorrow, 9th March, all girls from schools aged between 14 to 15 will be getting Gardasil 4 free of cost. Unfortunately, right now, because of the cost of the vaccine, it is being restricted only to the target age group, and it is being done through the school health program. So this is one step in treating or preventing HPV. But I think we are running late, so I don't want to talk more about this.
There's just one thing about the vaccines. Of course, the public sector is only rolling it out for girls, but the recommendations are to also vaccinate the boys. So we are in fact in the private sector recommending it not just in that age group, but even in older age group at high risk population.
So Trupti, I'd like to say in Cooper Hospital, with the help of Rotary, we have done 2 doses already for the people who have missed that from 17 to 26, and 350 medical students and doctors have paid 50% of the cost was paid by Rotary, 50% by them, because you have to have ownership and responsibility, and we took consent form, and that has been done, and we are going to give them the 3rd dose also at the concessional rate. So I think it's the way forward. We have to be proactive. But unfortunately, in the government program right now,
it's only
so some of the residents ask me, Madam, abhi inko to free mein mil raha hai. They are themselves doing the rollout, community medicine and this. But it is not free for them. But we have to look into it, maybe in the long run.
And actually Servivac, the one by Serum Institute, it's only 1,000 rupees a dose.
Actually, Servivac, they are giving at 1,200 in bulk. So for our Rotary program, we have residents have paid 600 and Rotary has paid 600. So and right now it's been a very good response with consent.
Thank you.
I just want to stress again that as Madam said, congenital syphilis is increasing. So is seroprevalence of VDRL positivity in antenatal women. Also, it has to be known that syphilis is completely treatable with injection benzathine penicillin. There has been no resistance known to injection benzathine penicillin in syphilis, okay? And it can be completely prevented by giving the mother or the pregnant woman injection benzathine penicillin. So we can completely prevent congenital syphilis. So, and it is safe. We regularly give injection benzathine penicillin to pregnant women with VDRS positive status, and it is completely safe. So I just wanted to inform this to the audience. Thank you so much.
I think we should give her a big hand. It's a very good talk, and celebrate the speaker.
No, there's one more speaker in this session after that. Oh, really? Okay.
I'm not sure if you would.
Yeah. You want to leave?
I'm not sure.
No, I thought we will felicitate after this. Can you hear that? No, we have one more speaker in this session. Oh, I see.
So we have one more speaker. Why screening is a game changer for cervical cancer prevention. So I think it is in continuation with what we have discussed.
Dr. Agrawal will also join as the chairperson. She's actually the chairperson for the next one, but running so late.
Welcome Dr. Gwen Stevens, a respected expert. She plays a pivotal role in advancing screening strategies and improving early detection approaches for cervical cancer prevention. Today, she speaks on why screening is the game changer for cervical cancer prevention.
Is it on?
Good morning, there we are. That was a fantastic segue into my conversation this morning, so thank you.
Good morning, everybody, and thank you really to the ASICON organisers for this post-conference workshop and for the opportunity to be here and address you on this really very important subject about HPV. We've heard a little bit of introduction to the problem we face with HPV infection. HPV is certainly one of the most common sexually transmitted infections worldwide, and yet it's the frequently missed infection. Without screening, because HPV remains predominantly asymptomatic, we don't know it exists. The only time we are alerted to the fact of an HPV infection is when a woman presents with cancer, with cervical cancer. So today I want to talk a little bit about why this matters so much and how HPV testing changes the prevention for cervical cancer globally. My talk will follow a very simple workflow. I'll look at why HPV is so often missed, what it means for cervical cancer, particularly in countries like Africa and India, and what is the global guidance that is driving the uptake and transition from our conventional ways of screening for cervical cancer to testing with HPV. And then I'll focus on how this actually has changed practice, what evidence exists in order to support the change. So why is it that HPV is often missed? I think we've spoken about it very eloquently in the last presentation when we talk about asymptomatic STIs that are overlooked because women are not presenting to health systems with any symptoms until it's too late. So we know HPV is extremely common. In India and in Africa, where I'm from, it's largely invisible. It infects the cervix through sexual contact, as we know, yet most infections cause no symptoms. Women are totally unaware that they're infected, and the majority of women actually clear HPV infection on their own. The risk arises when we have persistent infection of high-risk HPV that is not addressed. And in India, as in my country, it's low awareness, it's stigma around the fact that HPV is a sexually transmitted infection, and the reliance on symptom-based interventions that really presents itself with this really critical epidemic around cervical cancer. So the real challenge in India isn't how we treat cervical cancer, it's how we detect this silent, high-risk HPV infection early enough to prevent cancer. So cervical cancer is the second most common cancer occurring in women in India, and it's one of the leading causes of cancer-related deaths. We're looking at about 125 to 130,000 new cases of cervical cancer every year. And I have to remind you that cervical cancer is a completely preventable disease. If we think about it, it's the only cancer that we know how to treat, we know exactly what causes it, and we know how to prevent it. There is no other cancer like that. Yet we are still faced with 80,000 deaths annually from cervical cancer. That is 1/4 of all deaths from cervical cancer that occur in India alone. Why? Well, it's because most women are presenting with advanced disease, where treatment is complex and our outcomes are really poor. And this explains why mortality remains disproportionately high compared with countries who have organized screening programs. As I mentioned, it's persistent infection with high-risk HPV, right? And we know in 90 to 99% of cervical cancers, it is a high-risk HPV type that is the causal agent of cervical cancer. HPV 16 and 18 account for about 70% of all cervical cancers, and HPV 45 contributes the additional disease burden. Squamous cell carcinoma dominates in India, and it's not a rare disease, right? We look at the numbers, it's certainly not a rare disease. And it's not a failure of treatment, it's a failure of early detection. And this failure of early detection is driven by low screening coverage and reliance on symptom-based care. It's a bit of a mind shift when we talk about HPV. Because a woman is positive for high-risk HPV doesn't mean she has precancer or cancer. What it is a risk-based assessment of her potential risk to develop precancer and cancer. So it's a really early warning detection system for us that we should use to ensure that we are not faced with these 80,000 deaths annually from a totally preventable cancer. So, as we mentioned, cervical cancer develops over time, right, when we have these persistent infections of high-risk types. Most of them clear naturally, but it's only in really immunocompromised women where women are unable to clear the infection where we see the problem. So have a look at the graph at the top right. Most women are able to clear infection, which is the blue graph. It's only those that are unable to clear the high-risk infections that lead to the development over time of precancer and cancer. So what does this grant us? This grants us this huge window of opportunity where we can actually screen women and we can intervene before we could get to the development of precancer and ultimately invasive cervical cancer. So it's really a missed opportunity. This slide shows the WHO's cervical cancer elimination strategy. We hear all these figures, 95, 95, 95. When we talk about cervical cancer and the elimination targets, we talk about 90, 70, 90. That 90% of young girls need to be vaccinated between the ages of 9 and 14. And as you heard earlier, this is rolling out in India in the public sector very shortly. 70% of women need to be screened. Remember, vaccine coverage is still very low in a lot of countries, Africa, India included. We need to ensure that we are screening women who were not vaccinated and also who missed the vaccination rollout era. And then, of course, when we identify somebody with a precancerous lesion or cervical cancer, then we do something about it and we treat those women. The WHO classified the different high-risk HPV types. You can see them listed in the table there. 16, 18, and 45 are certainly the most high risk of all 14 high-risk types. There are 14 high-risk HPV types that are directly associated with cervical cancer. We talked about the pillars of prevention. Vaccination is certainly the primary pillar of prevention. You heard about the rollout. There are different types of vaccines. I think the vaccine that's rolling out in India as of next week is the Gardasil 4-valent vaccine, which vaccinates against 16, 18, and 2 low-risk types, which are 11 and 6, which are related to the genital warts, right? So you are vaccinating your girls against 16 and 18, which accounts for 70% of cervical cancer. The WHO also recommends testing and screening algorithms, and they divide it between the general population and the population of women living with HIV. You'll see that in all WHO recommendations, what they are recommending is screening with a high-performance HPV DNA assay, right? And also for implementation and for most effective programs, they are recommending this to take place in a screen and treat kind of environment, so that you see a woman, you screen her with HPV, and you treat her if needed on the same day before she exits the health system. In terms of the general population, screening needs to start at the age of 30, right? It's no good screening women early on. We know that 85% of us have HPV infection after sexual debut, but most of us are able to clear the HPV infection. So screening starts at 30. Very importantly, when we screen with HPV, our screening intervals are much further apart, right? With VIA and with cytology and pap smears, we are telling women to come back at least every 2 to 3 years. When we test somebody with HPV, if they're HPV negative, we're only suggesting that women get tested twice in their life. So those screening intervals are far longer, right? 5 to 10 year intervals. So women need to be screened at the age of 35 and 45, and that's it. In terms of HIV positive, a woman living with HIV, that screening takes place a little earlier, starting at the age of 25, because we've seen that they have a 6 times more greater risk of developing cervical cancer because they are unable to clear the HPV infection due to their immune status. But very clearly, WHO coming out and saying transition to HPV testing is where all countries should be going. So why is it such a game changer? So traditionally, we are screening with pap smears, liquid-based cytology, or VIA, visual inspection with acetic acid. We now know, and this is, almost 20 years of data, has now shown that molecular testing with HPV is far superior in terms of sensitivity than either conventional cytology, and of course, most certainly, more sensitive than visual inspection with acetic acid. These longer, safer testing intervals after a negative test help relieve the health system burden, and we're able to define a woman's risk really early on and intervene as necessary depending on what those high-risk HPV results are. So I'd like to just talk a little bit about what CEPHAD has to offer, and if for those of you who were at the ASICON conference yesterday, I did mention the fact that GeneXpert, and you heard a bit about GeneXpert already this morning, is rolled out extensively in India. You have more than 3,000 instruments across India, many of those existing in hospitals on the back of the TB program. Many of those are underutilized. So here with the opportunity to start screening women. Sorry, and I jumped over the one slide where you saw the map, but screening coverage in India and in Africa, and particularly South Africa where I live, is very poor. We have a screening coverage where I come from around 15%, and I think it's pretty similar in India. We need to ensure that we provide access to screening, and a simplified version of that is HPV DNA testing. So CEPHAD have an offering. It's the HPV version 2 assay. It is a PCR NAT-based assay, right? It detects the E6, E7 region of the viral genome, and it detects all 14 high-risk HPV types. 16, 18, and 45 are called out independently, and then the other 11 high-risk types are pooled results. And this is really important because partial genotyping has now become a very acceptable triage to determine where women should go next in terms of their patient pathway. We've heard already this morning, and it's the same in my country, women living with HIV, there's at least 50 to 70% high-risk HPV infectivity in that population. In the general population of women, it's slightly less, but in India, we've heard it's 30%. We have to understand what we're going to do with women who test positive for high-risk HPV. So a lot of the testing algorithms are now focused on partial genotyping. If I'm 16, 18, or 45 positive, I can be treated immediately with thermal ablation. If I fall into the category of less risky high risk, then I'm followed up with colposcopy. And if I'm in that sort of very low burden, high risk group, then I'm followed up more frequently. So importantly, that this product is able to do this partial genotyping. Very simple workflow, right? Sample into cartridge, cartridge into machine, 60 minutes later, you get a result. And I'm not going to go into too much detail here, I'll just move to this. So what does that mean for the patient? Well, it means simplified patient pathways, right? Sample to answer within 60 minutes. Woman can be treated, counseled on the same day as she's tested and screened. There's definitely been a policy shift in India, right? It's moving, the freight train has started, right? We're moving and shifting towards HPV DNA-based screening in India, aligning yourselves with the WHO elimination. There's certainly a lot of political will, and that's really what it takes. And by stating that elimination requires speed, scale, and system-wide alignment, really means that the science right, has been proven. What we need now is execution. We need to move from guidelines and policy to delivery. There's a lot of evidence to show that the GeneXpert HPV assay is equivalent to any of the large centralized testing platforms, and I'm not going to go into too much of the evidence, but that's all been published. This assay has been available since 2016, so we have 10 years worth of data to show performance. In addition to the many clinical trials that were done during product development, there have also been these very large sort of international validation studies showing exactly the same, that GeneXpert is really performs very well in terms of sensitivity and specificity, but moreover that it can be decentralized, right, in settings that conventionally are more outside and more accessible to women. The one sort of sentinel study that was done, and I've got a really nice video to play, it's about 4 minutes, so if there's time I wouldn't mind playing it, because it really puts in this study in context, right? The ability and the feasibility of testing and treating women on the same day before they leave the health system is really key and crucial and essential if we're talking about getting screening coverage to acceptable limits and thresholds.
So the organizers have asked you to play the video later because there are some speakers who have to leave.
No problem. So I will play it whenever you're ready to hear it, but it just provides context to the screen and treat kind of recommendation that the WHO is really suggesting needs to happen if we are to get a handle on what is a preventable cancer. And again, being here on Women's Day, I think is extremely appropriate to talk about a cancer that we know how to deal with, that still, remains a huge burden to women in developing countries. Thank you.
Thank you very much.
Can we have the lights? So what you spoke about is actually very important, that especially when liquid-based cytology is done by the gynecologist, you have the option of reflex HPV DNA testing. On the same sample, it is kept by the lab, and if you have a report which is showing coilocytes or some other risk factors, it can be done. So I'm glad you brought up that point, and definitely we have to up the ante and improve our screening programs to have a really robust screening. Thank you so much for that very important.
And just to make a point that HPV DNA testing is now become the gold standard. A lot of countries are transitioning as the primary screen, right? No need to do cytology and then reflex to HPV. HPV is the primary screening tool.
Yes, I have a question. Of course, the GeneXpert has been a game changer for TB and for detection of HPV. Now, this is a qualitative test. Is there any quantification possible in this? Because I have seen some papers of CT values and following it up with the CT values in order to see whether the virus has cleared.
So right now our assay is a qualitative assay, it's not quantitative. So any sort of interpretation of CT values in relation to quantitation would be considered off-label.
Yes.
It has been done, but what we have on label is a qualitative assay that delineates 14 high-risk HPV types.
Yes, and I must share that the results have been very matching with the C gene, where we have information about the other genotypes also. So what we really want to see now is that it is integrated in the national program. And as I told you, cost is the limiting factor. So as a company, if you could, negotiate a good cost with the National AIDS Control Organization, all the HIV clinics in public care facilities will stand to benefit. Thank you very much.
Thank you.
Thank you.
Sachi, we'll felicitate the speaker. Trupti, you should also come.
Yeah, let's have a picture. Come, Sachi. Come.
You should be in the center.
You should be in the center.
Yeah.
And we will all stand with our paws. Come, Sachi. Sachi, come on this side.
Why don't you have some time? 15 minutes. So for the next case-based discussion, I would like to call the chairpersons, Dr. Amay Purandare. You can come with it. Come. Dr. Rupal Padiyar and Dr. Anjumani.
And Dr. Trupti also.
Yeah. Thank you so much for joining us. And our next, what is your PowerPoint? Does it go directly with the dinner? सबका वीडियो प्ले कर दो उनका. Dr. Padmaja Samant is present. Yeah, but she can join us. Nana is also. And Siddesh is also. समोर नाही हा बाजूला आहे.
So, good afternoon everybody, I'm Dr. Shruti Parekh and today I'm going to discuss about a case regarding a serodiscordant couple and then take it forward from there. So, background is just to prevent horizontal vertical transmission, provide safe access to IVF and ART services in chronic infected people. So here, this is a girl, she was 33 years old. She came to us with 2 years of primary infertility. Otherwise, hormonal parameters okay, AMH of 0.5, follicular number 4. Tubes were patent, but her husband was known positive on antiretroviral therapy with an undetectable viral load, with good CD4 count and a normal sperm parameter. Before I go into more details, I just wanted to ask the panel, when a serodiscordant couple presents, what are the essential preconception assessments we would be doing before starting them on treatment?
So, if a serodiscordant couple is there, we would like to test them. There would be a panel of tests which are done in the, here the male is infected. Yes. So in the male, which would be deciding upon how infective he is going to be. So that is a first thing. So his viral load, his CD4 count, besides his semen, etc. Okay. So these are the two important things. I believe he would also be on ART. Yes. He's on ART. Yes. Then the ladies'
Can you just go to the previous slide?
Yeah. Yeah.
Who is undetected?
Now, she is negative.
She is negative.
She is negative. So ordinary investigations from infertility point of view for her, then their preparation or their counseling for PrEP. So then she has to have her follicular monitoring, etc., all that will be done. With PrEP, she has to have 28 days minimum of having the drug herself. And then the best period for unprotected sex, the counseling for whether they want insemination of a washed sperm sample or an unprotected sex. Now we have had patients, who have the desire to have natural conception. So we have to explain to them whatever the risk associated with that, a small risk, but it is a risk. And then whether giving a washed sample IUI, that would be the subsequent thing, and giving her a best period of whenever that unprotected is.
So going ahead, that's exactly what
Shruti, I want to make a point, because one aspect is the discordancy. But as women healthcare providers and especially fertility physicians, if you go to the first slide, we need to understand or develop some kind of a strategy as to how we would assist her in reproduction, achieving reproduction. Whether it will be more of the baseline interventions or baseline techniques, or whether it would be a proper IVF ART. If you go to see, her AMH level is pretty low, and her age is also close to 35 when the natural fertility starts receding. So we also need to know that, or decide rather, are we going to prioritize or are we going to press the pedal to get her pregnant as quickly as possible? And if that is so, and we make that decision, it could be based on her previous attempts to achieve pregnancy, the latency period of infertility, severity of infertility, etc., and her wishes as well. Then we need to start rethinking and recalibrating about what interventions we'll do and whether this discordancy will play a role in those interventions.
Absolutely, sir.
So I think here in this particular case, U is equal to U come into picture.
Correct. So that's where I'm coming to next, ma'am. So the first set was, of course, what are the prerequisites when a couple walks in. The next is how long should we wait for viral suppression before we start offering them fertility treatment.
And Shruti, you'll agree with me that they have decided they want a pregnancy, okay? We need to investigate and not compromise on any investigative diagnosis, any investigation which will help us in diagnosing their state of fertility. Okay? So we will not delay any of those tests that we would do if this discordancy was not in the picture. So one aspect is giving her the priority for managing her infertility, and the other thought process is now the discordancy coming in the way. But we will obviously not delay her investigation or starting investigation.
Correct. So once the investigation is done, it's recommended that viral suppression is the cornerstone. So HIV positive partners should be on effective antiretroviral. We target the U is equal to U concept, where we expect the undetectable to be untransmittable, and 6 months at least of viral suppression is what is offered before conception is attempted. And now comes this dilemma. Should natural conception be encouraged in this couple? If they say, madam, we don't want to consider jumping into IVF, then will we offer natural conception?
Definitely. I mean, this is just the perfect couple to encourage. And I think a lot of this fear is not from the couple. A lot of this fear is transferred from us to them. When we say we are expecting U is equal to U is not the point. U is equal to U. We have to say that again and again. Sometimes we take 1 year to convince the couple that you will be able to have a natural pregnancy. We take onus of keeping you undetectable because we have those tools. We have ART. So in this, we shouldn't give them options saying, do you want to have natural, do you want to have IUI? Because the moment you do that, you are doubting your own science.
Yes. So, Correct. So evidence supports U is equal to U. There is implications in fertility care because of reduced transmission risk and a possibility of natural conception in selected couples. However, ART may still be preferred if there is some infertility present. So with that low AMH, I'll come to what eventually happened to this patient, but ART may still be offered. Would you still prefer sperm wash? Because if you are now telling this couple that U is equal to U, there is no risk of transmission even if you try naturally. But now when I'm going to do the IUI and the ICSI, I'm going to wash and double prep and have the density used and then go ahead and do the, how do we justify this in today's concept of U is equal to U?
So, Shruti, two aspects. You're washing and improving the sperm concentration. But you're not washing and removing the HIV viral load. So these two key concepts that you need to make. Your viral load is anyway negligible. So what are you going to wash? You can't wash the virus. Okay, or rather it's not correct only. It's not scientifically correct.
But
so
the
you're
guidelines
washing.
At today's date still says that you should be using a double density gradient followed by a double swim up followed by double wash followed by a swim up and then check for RNA PCR at the end of the screen sample and then inseminate or use it for ICSI, which is where the controversy arises, is that if we're saying that the virus is untransmittable, then how are we justifying doing these procedures to our patients?
Two clinical philosophies we need to keep in mind. One is, are we compromising on science and safety? And number two, in our scenario especially, the cost effectivity. I think we have to weigh the balance keeping all these in mind.
So yes, the rationale being that the virus is mainly present in the seminal plasma or the leukocytes and sperm preparation is aimed to remove these so-called viral particles. Would you recommend pre-exposure prophylaxis to the female partner if they're trying to conceive naturally or via IUI?
No.
Yeah. So
Unnecessarily blaming her to be a positive patient or likely to be a positive. Nothing is there.
From the medical point of view, if the husband has undetected viral load, we do not need to give PrEP to the lady.
So I'll give you a little background for this couple. What eventually happened is, I'm going to come to these slides later, but she underwent an IVF cycle at the beginning before she presented to us. Because of her low AMH, unfortunately, she had very less egg yield. She had only 1 or 2 poor quality mature eggs that didn't yield her a pregnancy. And she was shattered because all she was told was you have to go for a donor egg cycle. And she was young, they had not attempted any intercourse because she was well aware of the serodiscordance. And she didn't know how to proceed from there. And that's where that previous question is, when we told her, in fact, there was a couple of rounds of counseling with the infectious disease specialist and our team, she was very scared to still try the unprotected intercourse, like the timed intercourse or trial without any protection, because she said, no, I understand all your data and I understand all your literature, I understand everything, but can I do something to protect myself further? And that is where this question came in, that if a patient desires to take pre-exposure prophylaxis, do we provide it? And what would be...
We've had these cases, okay? And there will be most who we will be able to convince that they don't need it. But if someone still insists, they have a choice and they can still go ahead and take it. Correct. At least they are moving ahead and planning a natural pregnancy. So at least let's support that.
So will there be a particular amount of time that you would want her to take the prophylaxis, or technically not?
Technically we don't want her, right? So I mean, for the unprotected period that she thinks.
Yeah, in the majority of the people here, there are women. We are on International Women's Day today. So I'd like to give a big yarn here that we can't impose contraception, we can't impose conception.
Yeah.
My professor, Dr. Salvi, is nodding in agreement.
The imposition of PrEP is there or not? So you have to answer that.
No, I said about, she said already about PrEP.
Yeah, exactly. We ideally don't need to give, but like you said, she just wants to be doubly sure. And that part you can only counsel, you can't force. So fair enough.
But for her, for a person like her, that remaining 5% will make her go mad.
Correct.
Not only 5%, even 0.5%.
0.5% is correct. So in this male, his CD4 was 480. So we decided to tell them to try. However, would this change if the CD4 was lesser, like 280, for example?
No. CD4 280, but what was the viral load? Undetected?
Still undetected.
Same thing. Then it doesn't matter.
Correct. So just an added point that if the CD4 levels are low, it basically does mean poorer general health, possibly, and therefore fertility outcomes could be poor. It's not that you need to wait for the CD4 to improve, but it's always beneficial to have both in tandem, that is a controlled viral load and a good CD4 count, which is going to show a stable HIV control for
That's more for the fertility bit, right? Not the infection.
Not the infectious. Yeah. Lab precautions, anybody would want to highlight upon? Or a case
There's such a big delay.
In your IVF lab,
yes, sir.
Shruti, I will leave it to you. I think we've got very standard guidelines now, both from the quality control agencies as well as from the clinical agencies.
Yes.
And I think we need to adhere from that for the best interest of the patient, both in terms of safety, quality and competence.
Correct.
So we should not differ from these, and we should stick to them as much as we can.
Absolutely, sir. So quickly just highlighting those, of course, this is universal precaution for absolutely everybody. This does not mean you have to take extra precaution just because this is a seropositive sample. Proper labeling is a must. In general, dedicated lab area could be offered, time slot. Cases usually scheduled at the end of the day. This is what is usually done. Closed vitrification devices. Sometimes dedicated storage tanks may be offered to positives and strict chain of custody.
Dr. Shruti, aren't we differing in what we are offering to women and what we are doing in the lab?
Absolutely. So I completely agree.
See, because on one side we say X-ray guidelines we need not follow. On the other side we say the lab guidelines we must follow. What are we? We have to have one standard.
Yeah.
So what is that one standard?
There isn't, no?
We have to
Unfortunately,
have
madam,
that we have to speak out. We have to spell out, you see.
We have to.
So what should be one guideline?
So unfortunately, that's exactly the we have contrary things going on. One where we say that we need to follow the U is equal to U. Universal precautions is all that's required. Like Trupti mentioned in her previous slide, that you don't even need to be having the kits, etc., because that patient is actually safer than somebody you've tested as HIV negative, which could be in the incubation period. However, this is precisely what our guidelines mention that we need to be doing in the lab. So we do have contradictory guidelines, but that's where we stand today. Coming to the opposite, where the female is positive and the male is negative, this is a little simpler. I think it's completely based on the infertility aspect for the female. It is not that complicated. They can be trying simple timed intercourse, ovulation induction in IUI, IVF or ICSI based on her fertility parameters, because the principal goal is prevention of vertical transmission. So an algorithm, quickly, we check the status of both partners, we optimize antiretroviral therapy if one is found positive, achieve the undetectable viral load, remember to screen for other STIs as well, offer in case she's wanting pre-exposure prophylaxis, she or he, and choose fertility treatment likewise. So just coming back to what eventually happened to that couple, they were counseled and they did manage to conceive spontaneously just on antioxidant therapy after failing an IVF elsewhere. So sometimes I feel like our current practices are more fear-driven than evidence-driven, and I would like to end with thoughts from the panel about what do you feel about this last point.
As I said, we require to have standard guidelines, because once we give a message to the couple that U is equal to U, absolutely fine, I have nothing against that. Some time ago we spoke about what the guilt of women, what is the expectation from the partner. So when those things are in the picture, what is going to be her subsequent sexual protection. This person is positive. He may remain the same virally suppressed person, or at some stage he may gradually not deteriorate.
But why will he?
No, I'm not. Why is we are not living their lives?
No, but
I'm not saying that. But if suppose he worsens, then still the same expectations of sexual freedom are there. So how are we going to, what is it that we are going to tell them, and how we are going to, I can't say control, but how are we going to keep them both safe? Is the next question.
So exactly, this was actually something I wanted to ask the panel, that suppose this couple conceived, actually it came in from one of my colleagues here, and they had a healthy baby and all is well, and now they want to know if that U is equal to U follows for future unprotected intercourse, which is not fertility driven.
You know, we are really focusing U is equal to U only for that baby.
Yeah.
There is another need for sex, right? Why is it that you're only talking about U is equal to U only for the child, or only for that period, or only for the 7
Precisely, that
days?
is what I asked.
Then how do we know that this husband is well controlled? So how frequently does he need to be doing his checks?
We follow them up every 6 months with a viral load. The regimens that we are using are super solid. There are no blips, there are no failures, there's nothing of that sort. So if the individual is virally suppressed, they will continue to be undetectable, and that lady will continue to be negative for the rest of her life. It just requires very good counseling and good monitoring, and believe me, they both work in the public setup, in the private setup. I mean, that's how we are reaching, that's how the goal is 95%, 95, right? There's a reason why it can be achieved.
Yeah.
So I think your answer here is very clear. It's all fear rather than evidence.
Yeah, so I think we need to keep the 5 S's in mind, because it's Shruti's presenting it. So first of all, that science should never be compromised. What is dictating her therapy, you give the scientific rationale. Number 2 is that you need to, because it's fertility, you need to be realistic in your success rates. You need to be very clear and transparent what her chances are, and advise her accordingly. Ethics will play a very important role here. Number 3 is that the safety of everybody, okay? We need to change our mindset. The you by you concept is coming in now, and we need to adopt it, okay? Because science has given us enough evidence now that we are not compromising safety in any which ways. The 4th important thing is that we need to ensure that we support her in her decision. A decision may be for natural conception, a decision may be for assisted conception, whatever it is, and we need to sit down and tell her what are the pros and cons with respect to her and her husband's status, okay? And last but not the least, we need to put her on surveillance, okay? That means the couple on surveillance, so that we ensure that this presumption that we have, that she'll be or he'll be undetected, okay, all their life, we are not making a false promise, we are backing it up with the viral load or surveillance program. So this is, I feel, the broader picture in managing this.
Absolutely. Thank you very much. I think we have another case.
I just have one question. Is this sperm wash done for all infertile couples, or you're looking at it only for discordant couples?
No. It is done as a part of ART procedures. If it is as infertility procedures, that is to get the better quality of sperm.
I think is to improve the quality of sperms.
So if we were to do an IUI or an ICSI for a non-discordant couple, I would have had, based on the motility or the the semen parameters, I would decide if I want to do a density gradient or I want to do a swim up or etc. Here I am offering them density gradient, then double wash, then swim up, then checking PCR. On what context? And it's a guideline, madam, to do all of this, which is where, as an ART clinic, we're actually debating, we're telling them that you are not going to transmit the disease. And here we are explaining to them why you need to do this list of sperm wash techniques, because we want to reduce your risk via what we are doing.
And we are going to dispose our equipment separately. Let us be honest to ourselves.
I think the guidelines are also evolving. We have come this far, let's hope that we go further.
So I will be the last man for the day, I think.
Ma'am has a case,
And
no? Have you have a case?
Madam is also case. I would probably say that women who are on ART, antiretroviral therapy, are not necessarily candidates for ART, which is assisted reproductive technology. So I am going to be presenting a case of my hospital. Here I would just like to say that we review the management of pregnancy and women with HIV, understand a few guidelines, and discuss how to prevent mother-to-child transmission and address the stigma. I want to talk about the stigma among healthcare workers when we are actually seeing patients with HIV. So this is my case. She was a 31-year-old, second gravida, and she knew that she is HIV positive, and she was well adherent to therapy. Her first child was delivered by a cesarean section for obstetric reasons. She had severe oligohydramnios and she had to undergo cesarean section in a private setup in my suburb. Now, after 4 years, they decided that, okay, I'm ready to start a family. Educated couple, well aware of all the pros and cons, knew that their viral load is nil, and they took an active decision that yes, we want to plan a baby. Got pregnant in the first shot. She has a male child. Both are seropositive.
When did they turn seropositive?
They knew that they were seropositive in the first pregnancy. At the first antenatal visit, when the ANC profile was done, that's when they found out that they are seropositive. Now she has taken an active decision to get pregnant again, and she continued her pregnancy till a particular point, after which the doctor who delivered her unfortunately passed away. So now she started looking for people who will deliver her. And what answer she got in a few hospitals that she went was, "Aap BMC mein jao." Now, I would like to just put the cat among the pigeons. Like if a person like this walks into the clinic, the most instant reaction for people is like, "हम HIV positive patient नहीं करते बाबा deliver. आपको जाना है BMC में जाओ." So anything that you want to
I'm
comment
from
on?
BMC.
Yeah, so I've lived my life in BMC. Now I'm into private hospital, and I am still continuing that. Okay, we can still do everything in private hospitals. Not necessary. I have a nursing home, a 10-bedded nursing home, and I still believe that we can still manage a patient in a nursing home also. But contemporary hospitals are saying, "Nahi, why should we take a chance?" So is there fear among the gynecologists?
Yeah, definitely, I think, because I am also from BMC, the medical, I am looking after the medical ART, madam is from BMC, looking after the ops and gynec. And yes, we get reference from as far as Kalyan, Dombivli,
Exactly.
referred to Cyan and KM. Moment she comes positive, referred to Cyan and KM.
Exactly.
And whatever now. So there is a fear. Like we are going in the era of U equals U. If the patient is well, and in fact in your case it's simpler, both are positive, both are on ART,
Exactly.
both are virally suppressed, really nothing to fear actually. Madam?
It's rather than fear, it's not fear, it's discrimination.
Yeah.
Let us say.
It's discrimination.
It's not fear.
It comes from ignorance.
So, and it comes from ignorance, it comes from attitude, not only ignorance.
Yeah. Because they charge double. They do deliveries, but they charge double. They increase the prices to double.
So you were...
Sir?
They've already bashed everybody, so.
Sir, you have lot of work to do.
No, I'm noting down everything.
And I think it's going to be a journey for all of us to kind of change that mindset.
So Siddesh, Dr. Damania is here and he's smiling. Just yesterday I was telling Trupti, I was remembering him because I'm the first student from the Gynec department of the OBGYN Gynec department of KEM for his postgraduate thesis of HIV in pregnancy. Way back, almost 25 years back.
30 years.
Yeah, almost more than 25 years back. I was looking at my thesis, that black this thing, my wife wanted me to throw it away. I was just telling Trupti, and now Trupti told me you need to do the thesis again.
25 years later.
Do it again. So I was remembering my postgraduate teacher and the staff room. Dr. Salvi was there in the staff room when this discussion was occurring 25, 30 years back. Okay, because I was collecting all my data from Wadia Hospital. That time, 99% of patients got referred to us from the private sector, and sir will agree. And I remember one emergency that we did around 6-7 HIV sections, one after the other. Dr. Kedar was here and Dr. Rajendra was here. Both of them were my lecturers. And they told me this morning we fought and we debated and all that. I said, but then our boss, Dr. Damania, was there. He supported us. So he said, yes, he has also changed after 25 years. And we also need to change after 25 years. The moral of the story is that we are now better equipped with managing HIV. This has evolved. We are also better equipped in managing HIV in pregnancy, okay, because we've understood the therapy has evolved. It's been a long time now, and therefore, like in your patient, I think the obstetric decision will prioritize what route of childbirth or what decision of childbirth will be there. One other point that I want to make is that we need to keep in mind, here we are talking about this and all of us are saying, no, you by you, etc. In Foxy, that is the largest association of gynecologists, we are 40,000 of us. It's difficult to convince 40,000. Their resources are different, their mindsets are different, their clients are different, okay? Their client's perception for you is different, and the circumstances that they are working in with respect to their infrastructure, both internal and external, are different. So this has to be a mindset movement. Just like the first wave, you are an ID, so you know that the first wave of infection comes like that, the second wave of infection. So the first wave of infection came when we realized that HIV was a reality and we had to detect it. Okay, we just went left, right and center, okay, to detect HIV. Sir will agree, every time the patient walked into the OPD, I looked at her कि ये इसको पकड़ो ये मेरे thesis के लिए है. We moved from that. We developed our criteria. Now we moved to understand we have better criteria, better therapy. We need to now come to a point where we have to judiciously think whom we have to screen and whom we have to. Coming to the last point about how we can bring this change in a small nursing home or in a private sector. I'm associated with the Manyata movement. The Manyata movement runs with Japaigo, that is John Hopkins, and we constantly are talking to private facility owners because it is for private facility owners, and we have a dedicated module on HIV. So when I go back tomorrow, okay, in my review meeting, I'm going to say we need to relook at this. And at least those 4,000 nursing homes that have enrolled in Manyata for their quality care, I need to go and tell them that listen, don't fear it, change your mindset, at least try to change it, because you're not compromising your safety, you're not compromising the patient's safety, your staff's safety. Perhaps they will listen, but we have to make that change.
We are Manyata certified, so that gives us the confidence to go ahead with things.
Just one point, like Dr. Siddesh had said in between also, the other thing is the availability of pre-ART for the bachu,
Right.
that never-bring for the bachu.
I will speak on
Sometimes, yeah, that's not available, and so that hesitation is there.
So here, continuing with the case, eventually she landed up with oligohydramnios in this pregnancy also. I gave her a choice of trial of a cesarean section versus a repeat cesarean section. And the couple decided, no, we don't want to take any chances. I don't want any transmission risk. That time it was not so evident that U is equal to U. I did not know and I could not convey to her that come what may, we will deliver you naturally. But then, since it was a planned previous cesarean section, we went ahead with the cesarean section, and the cesarean section was uneventful, and baby was fine. Baby was given post-op prophylaxis. Now here, this is one point I want to highlight, that we tried to find out where can we get the nevirapine syrup from, and we were approached by somebody saying, no, we will provide it to you. This was a female who had given this patient nevirapine in the previous delivery also. Now, since it's a close-knit network, she had those numbers and she said, okay, I'll call that person. Last time bhi unhone mujhe aake diya tha. Now, when I spoke to her, she said she will charge something. I said, no, this is not chargeable. This is free of cost. And then we approached the nearest BMC hospital. The husband went to the hospital and got that immediately. So, just highlighting the fact that there is no charge involved in the NACO, in the PND, PPTCT Act. Everything is provided by the government free of cost. Anything that you want to say about the availability?
From the way you have put it, I do not know when that hunt for medicine started, but all this has to be planned because it has been known to them.
This was ready with us on the day we got to know that there is a cost involved. That cost was not spoken to till the day of the delivery.
Because it is to be given immediately at birth. So that has to be ready, and that all planning has to be done. See, the problem with the baby's feeds, baby's medication, everything starts after the baby comes.
Correct.
That is the problem. It has to be started much earlier.
So as I asked them initially, they said you have a 72-hour window till which you can give the nevirapine syrup to the baby, but earlier the better. Earlier the better.
So just like we talk about early initiation of breastfeeding and preparedness for childbirth, and then after childbirth in the immediate post-delivery period, and then when the mother goes home, we have got all these kind of hand-holding things in Manyata. I think we need to also look at the counseling aspect. The government-based programs have a dedicated person. Once you opt in, opt out, etc., start talking to you about what would be baby care immediately after birth, and obviously the resources are provided for the medications, breastfeeding, etc. But we need to take that onus on us, as Dr. Padmaja Samant said, and discuss these, not just the obstetric implications, but even the neonatal implications. We'd be better prepared.
This female was well aware of the risks of transmission, and she said, no, I want to exclusively breastfeed my baby. And we supported her fully in this decision, and she exclusively breastfed the baby. Uneventful discharge on third day. The first follow-up and the second follow-up of the baby still turned out to be negative, which was expected. So here I just want to highlight this hidden barrier, the stigma in healthcare, that why are we still afraid of HIV? As a resident doctor, when I did residency in 2002, we were afraid that seropositive, make sure that everything is taken care of. Eventually, what happened was where I did my PG, there was a separate set of instruments for those who were seropositive. Those were not used. The speculum was different. The OT tray was different. I think autoclave is enough to kill HIV as a virus, and I don't know whether we genuinely need a separate set of instruments also for such people. But evidence shows that standard precautions are protective, and as we have learned from here since morning, that we treat every patient as they are potentially infectious and there is no specific extra care required. Treat the patient and not the virus. So why is this fear? Is it fear of getting infected yourself? Is your staff afraid that ho jayega? They are the ones who are probably not as aware as we are. But then we need to also percolate it to your nurses, your support staff, that, okay, I know U is equal to U. But then when I try to convince them that U is equal to U, they are from a different educational, socio-cultural background. We've probably gone through more vigorous training where we are okay to accept, understand, and take the change. For them, we will have to train them, and they need to get to the point, sensitization of the staff. Do they feel that they're inadequately equipped, that no, mera instrument kharab ho jayega, what if there's another patient later? If I block my OT and I have to fumigate, I have one operation theatre. If that operation theatre is blocked, if there's a patient who comes back for another case, there's so many things that go on in a nursing home or a private hospital setup. And so this is something, plus social dimensions.
Just want to make a point, Siddesh, may allow me, that we need to stop the blame game.
Yes.
Number one. Number two is that we need to lead by example. You are the leader of your team. If you say that you are not fearing this, okay, we saw that in COVID. Okay, if the captain only was weak and scared, the team crumbled. But if the captain said, listen, I've taken the proper precautions, this is our responsibility, we are doing it for another human being, okay, we need to do this, we'll do everything possible that is there scientifically, it will just motivate and bring up the morale of the entire team, and you will be able to provide these services.
Yes, sir.
Another point that I want to make is that we also have to start developing a liaison with the authorities, a liaison with the government setups, etc. And if they see that, yeah, you're genuinely caring for the patient and you're genuinely wanting to offer services in your limited resources, they will also do best to help you as much as you can, as they can. So
So hearing he kept mentioned about the access to Nevirapine just after delivery and they were contacting some person, etc. So my appeal over here is, at least with the MOGS and MDAX, is that if this information that you are expecting an HIV positive woman to be having this much ADD, etc., officially the Nevirapine or whatever ARV prophylaxis is required can be accessed from MDAX. Also, EID, I mean early infant diagnosis testing, that is available in Kasturba, even that can be done, and entire follow-up. I mean, the woman and the couple has a choice to take treatment from whichever sector, but ensuring that the baby is protected and is tested at the right time, because gynecologist may not be calling her for follow-up at 6 weeks. It goes under the realm of pediatrician, neonatologist, etc. And then you may lose contact also, because for GOI, the baby mother pair is followed up till 1.5 years, till we declare that the baby is negative. So this is a chance for that active, proactive public-private sector engagement. And since both bodies are here, I think this should be followed up as your module in program.
I think I'll just wrap up with a few slides where now.
Assurance that it's coming directly
Yes,
from
it's fantastic because it does release a lot of stress for situations where suppose someone walks in, she turns out positive, you're not mentally prepared, and then where to get it from. At least you know who is the contact person and whom to get in touch with so that things are quick. Just summarizing the epidemiology, that with ART and viral suppression, the transmission rate is negligible. With those who have no viral load, as we've spoken since morning, there's hardly any transmission. So this, I don't want to go through these are just basic slides where all can the transmission take place. The WHO CDC aims at eliminating HIV as a public health threat by 2030. I think we will get there soon. The NACO says that you should be universally screening HIV during pregnancy. All these points have already been spoken about. I don't want to run through these. Even the ACOG says that, as speaking about the mode of delivery, that also people have spoken about, that vaginal delivery is acceptable if viral load is less than 1,000, and cesarean only if viral load is more than 1,000. And the RCOG goes on to say that viral load less than 50 copies, vaginal delivery is recommended. So here again, the stigma among healthcare professionals and gynecologists that if the patient is HIV positive, she 100% needs a cesarean section does not exist. Please clear that in our heads, that she can still undergo vaginal delivery, only obstetric indications are indications.
So you're looking at the BIVA guidelines.
Yes.
That's why.
Yes.
If you look at the NACO guidelines, less than 1,000.
Yes, less than 1,000. So at 36 weeks, as we spoke about, we need to do the viral load, and if the viral load is less, we can still offer a vaginal delivery. If the viral load is high, we may consider a cesarean section. Neonatal management also has been spoken about. We need to give as early as possible. I will just go to. This is just what I feel, my advice, that while operating a patient who is HIV positive, if you do not know the viral load, let the senior surgeon operate. Let not a junior take over the case. Keep the assistance to be minimum. I think Dr. Lakshmi spoke in the morning that don't put your hands in when you're doing a cesarean section, use retractors wherever possible. Keep the senior sister as your scrub nurse, not some junior nurse who will fidget with the instruments. Handle the sharps carefully. Make sure that if you can guard your needle before handing back your needle to your assistant, please handle. Needles mindfully handed over. Don't leave trailing needles on the surgical field. you use protective gear, and this protective gear is irrespective of whether she's positive or not. But then there are many people who forget to wear eyeglasses. Also make sure that you're covering your eyes, because the eyes get fog. As a surgeon, I know that my eyes fog and I keep removing the glasses again and again and again. So make sure your eyes are covered. And in case one fears that instruments are infected and cannot be used, then you may choose to keep another tray separately, just as a placebo in your head that this tray is separate. Use suction adequately when you're doing a cesarean section, because things will keep falling down, and when things keep mopping on the floor, use adequate hypochlorite and make sure that you have disposable drapes. You don't need to wash them and use them again and again. For counseling, we need to counsel our patient that they need to adhere to ART, and I think the infectious disease specialists are doing a fantastic job. For us, we see them just once in their lifetime when they are pregnant, or maybe a second time. You are the ones who are dealing with them and living their lives with them also, counseling day in, day out, seeing an adolescent also, seeing a menopausal also, seeing them pass through all phases of life. Whenever an antenatal patient comes to, please discuss a proper delivery plan, educate them about the infant prophylaxis, because there are people, uneducated, poor people, road-sided people who may not give the drug at times. We need to hammer it to them that yes, you have to keep giving therapy whenever required. Encourage partner testing. This is something that we spoke about in the morning, that we need to also test the partners. In a private setup where I'm testing, I'm screening the wife for antenatal profiling, which includes everything under the sun, but I'm not testing the husband. But now on today, I'm taking the decision that I will also test the husband, at least for HIV, because we want to prevent the transmission in case there is a serodiscordance there. In fact, triple HIV, what will you recommend? Just HIV or everything for the husband as well?
You know, it's your opportunity to actually pick up one additional case. And since we're talking about triple elimination of hepatitis, syphilis and HIV, it's your one opportunity. Screen for all four.
And what consent do we take when we screen the husband? Just your wife is pregnant, so I will screen you as well.
No, it's an opt-out. No, give them an option. If they say no, you let them be. We can't force them.
So if they refuse, we will not test.
It's not a compulsion.
It's not a compulsion.
You can offer them.
It's an opportunity you're trying to use. It can't be enforced at all. It's
We
not
can't even force a pregnant woman.
That's right. Exactly.
So here there is no question of forcing.
Yeah.
Okay. So pregnancy and HIV have excellent outcomes, and viral suppression can reduce transmission almost negligible. I don't know this 1%, maybe less than that as well. Delivery depends. Then it is no. And education reduces stigma and fear, and yes, undetectable is untransmissible. So this is something that I want to end with, that U is equal to U, and everyone make sure that you get your patients to a point where the viral load is undetectable. So then everything in your head is clear that there is no virus here, I am not going to get infected, nor is my staff going to get infected. And she is potentially as any other patient to you in your clinic. Thank you so much.
Thank you. We have time or we don't have time?
But there's something.
No, there is nothing. It is about the...
But let's discuss whatever you had in mind, no? At least, even if not from the case.
No, I'm not going to elaborately tell about the case, like I have no presentation, but it was a surprise to me when, this was the era when NGOs used to provide those formula feed tins and all in the OPDs, so that the patients could do top feeding in an affordable manner, you can see. And one of the patients who was, she looked slightly, easily identifiable, so her face had remained in my mind. And she used to regularly take the tins and she used to feed her baby. Of course, that must have been the reason. And where was she living? One day I found out when I was walking up the stairs of Parla Station Bridge. She was living on the platform. So what was she doing about preparation of the feed? What I mean to drive home is that every woman has that extreme desire to not let the baby be positive. She wants best of whatever she can give to the child. She wanted to give replacement feeding because replacement feeding will reduce the chance of the baby getting positive. So, and she was a platform dweller. After that, later on what has happened to the baby, I have no clue. But in this light, what AFA's criteria are and how we are going to maintain those women. And one more important thing that we must remember is that after delivery, there are a lot of advices and family members' suggestions and, you know, मैंने 6 बच्चे बड़े किए, तुमने कितने बड़े किए? Mother-in-law will say, mother will say something, aunt will say something, everybody will have some input to give. So, दवाएं गरम पड़ती है, there are lot of things that come the patient's way. So, her adherence to the medication, it's something at that time we have to really counsel her very strongly for that. Because baby's medication and mother's medication, if she has not declared that status to the family and there is no support from the family, then the whole thing will crumble. So getting the one family member at least who can support her, especially if she is going to top feed, because somebody has to be there to prepare all those things and all that. And are we looking at working women and women who are not working and who are at home? So somebody who is at home can prepare all the feeds. Working women require somebody who is very skilled and she can prepare the feeds well. So this is about the feeding things which I wanted to bring home about in this case. So that's all.
So actually the concept of you is equal to you, a mother can breastfeed her baby.
So we don't have to think about artificial feeds because that's more risky in a country like ours.
Absolutely.
You'll lose a baby from aspirations, septicemia, diarrhea, pneumonia. So
and
dehydration.
I just wanted to lay stress on here that
NACO guidelines state that as far as possible breastfeed only if the mother is gone or the mother is extremely sick. Absolutely, she cannot breastfeed her baby.
Then we should be, but still we have to tell them and we have to, options have to be made clear to them.
And we have found that informed choice, I agree, informed choice, but when you explain everything to them, 95% of them opt for breastfeeding. The second thing is that in many of our cases, only the husband and wife know that they are living with HIV. The rest of the family doesn't know and they manage very well. We have no issues.
I have seen otherwise. In our hospital also, where the poorest of the poor patients come, there is a female family member who accompanies her. That means that they are sort of trusting somebody and divulging their report, and those women support them.
As long as they are supporting, there's no problem.
Because it is not an easy job to rear a baby and that feeding things and all that in such situation. So I've seen it.
Thank you so much.
Thank you so much, and we will request Dr. Glory to. The idea of the potted plant was to have something that grows. So I think we hope the collaboration, our updates, this has been a fabulous platform. I think we had all stakeholders, MDAX was here, and I really hope that we are able to work on this together. Thank you so much to everyone from MOGS to really support this collaboration. And please join us for lunch. Oh, sorry. Dr. Mandar is here. He is the MMC observer. We had a wonderful session, sir, with the finance and the district and the state AIDS Control Society and AIDS Society of India. She's here, yeah. Srikala madam is here.